Good morning. Good morning, everybody. While we're sort of gathering and maybe finishing conversations and coming into the room, I just wanted to show you a couple of things that we touched on yesterday. These are just a couple ways to keep in touch with us and that we try and keep in touch with you guys. So I just wanted to show you our Facebook page, which is Cure Ocular Melanoma on Facebook. And we post almost every day, but several times a week, and always try and keep everyone updated on the latest in ocular melanoma, anything in general melanoma that's relevant, and also Cure OM news. And then also we have a Twitter account. And so you can keep in touch with us both of those ways, and in addition to our website, which we really work to keep updated and on target. So I just wanted to show you those two things. I hope everyone slept well. Thank you all for being back here today. I think we have another really special day and some really wonderful speakers today. Before we get started with our first speaker, I just want to highlight that from 9:30 to 10:45, we have the panel, Liver-Directed Therapies and Local Therapies for Metastatic Disease, and that will be in this room for those of you who want to be here for that session. We also have a concurrent session, and I just wanted to give you the title of it because what we have on the agenda may not capture it completely. And is that going to be next door or in the... Okay, so the concurrent session will be next door in room number 5. And the title that Carmela has given us is Understanding the Cycles of Grief, Moving Through Loss and the Transformation of Hope in Presence of Life-Threatening Illness. So I didn't want anyone to think that that was, about grieving process of losing someone in particular, but she's actually does a lot of grief work with cancer survivors and everything that we all lose along the way, just from the first day of diagnosis throughout. So I just wanted everyone to kind of understand what that session is about for those of you who want to attend that session. All right. Well, with that, I want to introduce our first speaker of the day, which I'm just really thrilled to be able to introduce her. We have former Louisiana Governor Kathleen Blanco with us, as many of you know, and she's coming to us, as many of us have come to this meeting as well, as a patient, and so she's going to speak to us, give us a patient's perspective to open the meeting today. So if we could give Governor Blanco a round of applause. Thank you so much for being here.
Thank you, Sara. Good morning, everyone. Good morning. Are you awake? I don't do mornings anymore very well, but I am. I just want to say thank you to all of you for being here. You know, most speakers begin by saying that they're pleased to be invited to speak to the group. And I just want to say I find it odd to say that because I guess it's just because of the reason I was invited. It's hard to be pleased that you have ocular melanoma. And I think all of you will find that to be the truth in your hearts too. But I can say that I am very pleased to have had the privilege of meeting so many wonderful people. It's a journey for all of us. And I am pleased to know that research is being done. And I think that's something important for all of us. And I do want to thank Dr. Tim Turnham and Dr. Sara Selig for inviting me, because I think that it's really an honor to get to speak to fellow cancer survivors. And that thought hit me actually at my last doctor's visit, when my doctor said, "You are a cancer survivor and you're always going to be a cancer survivor." And I hadn't quite thought about my particular dilemma that way, but it is the truth. And the word survivor has a lot of hope. It's a really good word. It's a strong word. It's full of hope that is born of challenges. It's not a simple word because to survive, you have to have gone through something tough. And we're all going through something tough. We're survivors who cannot rest on our laurels And in that way, we're very similar to many other cancer patients. But I think that ours has a unique urgency about it, of course. Our battles are never done. They are never done. The way toward long-term survival, though, is to support those who are working to pry secrets from the universe that will offer us a cure. So that's why my husband Raymond, who is a great supporter of mine, and I thank him for it, that's why Raymond and I are pleased to be here at this Melanoma Research Foundation's conference. When I was first diagnosed with ocular melanoma, like all of you, my world was rocked. I thought I had met enough challenges in my lifetime to be able to coast through this. I thought I was going to coast through senior citizen status, actually, just doing lots of what I consider, or many of us consider, normal things, like traveling with my husband, gardening, writing, tending to our children, our grown children, our 10 grandchildren. Life looked pretty good for a good while. And I guess I should have known better. Life is just too perfect and it can't stay that way. And I'm no stranger to challenges. I had to fight to bring sanity to a state turned upside down by not just Hurricane Katrina, but Hurricane Rita, which hit the west side of our state less than a month later. So my whole coast was compromised. With a lot of hard work from thousands and thousands of people, both in Louisiana and volunteers who came from all over the country, really all over the world, we managed to work our way out of our misery. And because of the building blocks I was able to put in place, we have had a strong recovery. So if you haven't visited Louisiana in a while, this is an invitation for you to do so. We have better levees, we have better schools, we have better homes. We even have a Super Bowl win under our belt. Go Saints, So something you might not know, though, about me is that I had to fight a battle 16 years ago for my family's survival after the accidental death of our 19-year-old son. And that was a rougher personal challenge. It brought a lot of dark days to our world, but we all managed to survive. We did. We survived. So thankfully, very thankfully, I want to say that I'm so glad my life hasn't always been about rough passages. I've had some pretty special experiences, too. I'd say being one of, I think, 36 women ever to serve as governor in one of our states, in any of our states in the United States, gave me membership into a rather exclusive club. Through 24 years of public service, I've had the unique experience of meeting with presidents, premiers, princes, princesses, popes, emirs, living saints, actors and actresses, and I even met an actual dictator. All in all, my interesting life has been pretty special. But back to the challenges. I never experienced anything as upfront and personal as this diagnosis of ocular melanoma. And I suspect you feel the same way. In the immediate hours and days after my diagnosis, I was hungry for information. I had a need to know. So don't you just love the internet? Well, unfortunately, though, as you learned from your when you were first diagnosed, I found out that I had been volunteered into yet another small, rare, and exclusive group. Now, just how special is that? It reminds me of Groucho Marx's line, "I'd rather not be in a club that would have me as a member." Especially this one, the one we have. But here I am. Here we all are. I'm a member, and because I benefited from hearing of others' journeys down this same road with its treacherous twists and turns, I'm happy to share mine with you. It's hard to believe that my journey began less than 2 years ago. It was May 31st of 2011 when I visited my ophthalmologist thinking that I was going to schedule a routine cataract surgery. I had a very small cataract, but right in the center of my eye, which gave me lots of vision problems. So I was really looking forward to being able to have clearer vision. The pre-op exam turned into a diagnosis of ocular melanoma, this rare and dangerous cancer, I was told. Of course, I'd never heard of it before. Several doctors and eye specialists and others said that my best chance for survival would likely be to have my eye enucleated. Now, I never knew that such an interesting word, enucleation, exists for having eyes removed. So it's vocabulary building time, right, ladies and gentlemen? We are learning a lot of new words on our journey. If you're here as a patient, our journeys probably have a parallel track. I headed here to MD Anderson Cancer Center in Houston, where more eye tests, x-rays, blood work, and a CT scan and MRI confirmed the diagnosis. Couldn't escape it. Because my tumor was described as a medium-sized, I learned that I had choices besides enucleation. You see, I came here thinking that I was going to have enucleation, but I learned that I could go with other treatment options like plaque radiation or proton beam radiation, treatments which might give me a chance to retain my eye and particularly my vision for some time or for a period of time. Since I had been convinced that I'd have better odds of survival against mitigating against future metastasis by having my eye removed, it was suggested to me here that I get a second and third opinion from other doctors in other parts of the country. I went home still anticipating enucleation. I just thought it's just not that hard to choose between an eye and a life. It's just not that hard. But so I was kind of surprised that I learned that I did have an option. That took me by surprise, and interestingly enough, it took me a while to accept that I did have an option. My family was frightened to death, and to relieve the worry on their faces and let them know that I was okay, we came back from Houston and went straight to my daughter's house where a little party was happening. And the first thing I told my grandchildren was, okay, ladies and gentlemen, I'm going to take a poll. I'm going to take a poll, and they all stopped and looked at me, and I said, okay, I've got two options here. You know, if you get your eye removed, you get a fake eye. And I said, now I've got blue eyes. What do you think if I get a brown fake eye and I have one of each? Well, my grandchildren just started killing themselves laughing, you know. And I said, well, wait a minute, it makes so much sense. You know, the Louisiana state dog is a Catahoula hound, and it has a brown eye and a blue eye, and I look just like the Louisiana Catahoula hound. And so, and I said, and you know, it bites people, and I could go around biting people when I get aggravated. And my granddaughter said, oh, Mumsy, how many times have you ever bitten anybody? I said, well, not now, but, you know, if I'm a Catahoula hound, I might want to. But anyway, you know, it was just something to relieve the stress. I had lots of friends in the legislature who were apoplectic. I mean, they were so, they were just so upset about the thing, and I kept getting calls and calls. So I finally told them, I said, look, when I get my eye taken out, I'm going to have it preserved, and I'm going to buy a fancy little jar. And, you know, and so when you guys get a little wild over there in Baton Rouge at the state capitol, I'm going to send it for a visit, and I'm going to say, I'm keeping my eye on you. Well, you know, the truth is that all of their fears and their panic was just wearing me out. It was wearing me out. I had to create diversion so that I could deal with my problem. I just focused on getting opinions from doctors who actually treat melanoma. I had to turn the rest of the world out because many doctors who are general doctors in many other fields, even specialists, have only learned that you immediately have your eye removed because it's the only path to survival. But, you know, just finding doctors who treat this melanoma is quite a challenge in itself because There are only 12 or 15 doctors in the whole country, it seems, or 12 or 15 centers in the whole country that have doctors who know how to treat ocular melanoma. So I consulted on advice from here with doctors in Memphis and in Boston, and I began extensive research regarding treatment options for this choroidal melanoma of mine until I really fully understood my personal situation. And then it became clear. I learned that I could not count on enucleation for insurance against metastasis. There's no insurance. And therefore, then I began to rethink that whole picture, okay? I wanted an insurance policy, and it was not available. It was not for sale. So in that case, since I had a medium-sized melanoma, and I did have a choice, I decided, well, why not keep my eye just a little longer, or as long as possible, and take that chance and see what would happen. But, you know, making that decision was really hard. I was hoping that a doctor would help me to choose which procedure I should adopt. And that didn't happen. I had to choose and be responsible for the consequences of that decision. And you know, you second guess yourself all the time when you're in a place where there's no clear path. But I did choose radiation therapy, and I must admit that having an object sewn onto my eyeball was far more tolerable than anything I would have imagined. With a patch on my affected eye for a week, though, I also learned how challenging but not impossible it is to operate with just one eye. After brachytherapy, I went home looking like the red eye special. My vision gradually improved while I spent the next few weeks being extra kind to myself. You know, I've been a caretaker all my life, and taking care of myself in these circumstances was a unique experience. After a time, my eye no longer looked like a raisinette. It finally looked like a normal eye. The vision in my treated eye improved enough for me to start driving without scaring myself. And I am still regularly checked by my local doctors to ward off unseen problems. And you know, and I go for my checkups. My 6-month checkups now is on the 3-month schedule, and now it's 6 months. I thought I had gotten pretty relaxed about dealing with this cancer at first, so I was surprised to feel pervasive nervousness leading up to my first 6-month checkup. I knew that the odds of reducing these tumors with radiation are very high, but I also had learned that a small percentage of people do not respond well to radiation and have to have the cancerous eye removed after all. So I began to worry if I had chosen the wrong path. And until I got the good news, when my fears were finally relieved, I learned that my tumor had shrank and there was no evidence of metastasis, and I just wanted to say hallelujah. And by the way, I must confess that I have never been able to walk in relaxed at any follow-up visits, which have all produced good news thus far, for which I'm extremely grateful. I still had a bit of swelling in the macula of my eye, which was affecting the clarity of my vision. So I was given a shot right into my eyeball, which, you know, didn't bother me. I just closed my eyes and just let him do it. But my family members were there, my husband and a couple of my daughters. They almost fainted, you know, watching the doctor do that. I have had cataract surgery to remove the vicious cataract that came upon me and stole my vision, and I'm doing fairly well with my eye. It seems the radiation is doing its intended job, and the tumor continues to shrink. So the main thing I worry about now, like many of you, is if a stray microscopic melanoma cell takes up housekeeping in my liver. I thought my experience was frightening, until I learned of a young woman in southwest Louisiana recently who had an ocular melanoma diagnosis. And she had a diagnosis of an extra large tumor. So she started lining up appointments for treatment and learned that the health insurance company from her new employer denied her coverage. The first cancer center she contacted told her since she had no insurance, she had to bring $160,000 and they would treat her. With no money, this 40-year-old surgery scrub nurse who had been saving lives for years and single mother of 2 was desperate, and she saw her life melting away. And this is the power of the internet and communicating with people. Her aunt shared that story with me on my Caring Bridge site. And that's when I realized how few people know how to manage through a situation that difficult. And heaven help us if we don't have insurance. That's a really rough road. I finally found, after some difficulties, I finally found a Good Samaritan to treat her. And her future is now hopeful, more hopeful than it was. But she didn't have time to fight with the insurance company. She just wanted to get on with it. She was medical. She understood the differences. And the insurance company was contending that it was something that she knew about, that it was a pre-existing condition. That was their argument. It took months, but they finally agreed to pay. But if she had had to wait all that time, her chances of metastasis were growing rapidly. And she doesn't know now, as most of us, if that is going to be part of her life or not. It's important to communicate with each other, and that's another good reason to come to patient conferences like this. We can help each other, not just to navigate the medical system, but by sharing valuable insights. I don't know about you, but I'm not thrilled to know that this particular cancer is considered an orphan disease. In other words, there are so few cases in our country. Somewhere between 2,000 and 2,500 are found each year. And about half of those will metastasize over some period of time. So that's a relatively small number in this country of hundreds of millions. Therefore, very few resources are made available to search for the elusive cure of ocular melanoma. You see, it's always about money. That money, we are considered what business people call bad ROI. We are a bad investment, return on investment. That's our problem. The pharmaceutical companies look at the number of possible patients who will buy their products once their product is developed. They figure it will take forever and maybe never to get paid back on their research investment. So they do not invest in our problem because our numbers are too small to support the cost of research and development. But that does not make it less important to find a cure for us. I'm glad I came here this weekend because I heard a new note. When Dr. Scott Woodman said that researchers like to have rare cancers, because I guess it's because the pool of possible problems is so narrow that it makes it somewhat more interesting or maybe possible to find a cure. Well, I want him to know, hurry up and find it. We've got a lot of orphans waiting for that cure. But when you learn that in the greater world out there, that there is minimal effort toward finding a cure, toward funding research, it makes it feel like a very lonely world. This is not a paid political announcement, but let me say I heartily approve of the following message. We rely on organizations like this, the Melanoma Research Foundation, which, thanks to Dr. Sara Selig, now has a program emphasis on ocular melanoma. The foundation raises money to fund research and development, and they're looking for drugs or unique treatments that will make a difference in our lives. It supports all of us who are battling the fear of possible metastasis, are already confronting its arrival, and finding limited treatment options. If we can help the foundation in any way that we can figure out, then we should do that. And I am planning to go home and make a difference and find a way to help. Like you, all cancer survivors, I will be having semi-annual tests for years to come, and at least annually, for life to monitor if mischief is afoot. I'm hoping, like you, that you who have not yet metastasized, that I'm walking on the lucky side of the street, because half the people we know will not metastasize. But we don't know if we're in that half. I'm learning how to live with that Damocles sword hanging over my head, and hoping that that single horsehair that it's suspended on is strong and that it never frays. One thing that I like to do is remind all people that I speak to, whether it's public speaking or just a one-on-one, is I remind people to go have a dilated eye exam by an ophthalmologist. So many people never think about that because, especially if they don't wear glasses, they never go to a doctor. And sometimes if they do wear glasses, they only go to a doctor that doesn't necessarily do as comprehensive of an exam. And I just emphasize that. Get a dilated eye exam. Of course, none of us wants a cancer, but if one presents itself, we need to know about it as soon as possible because odds of survival are that much greater. In closing, I deeply appreciate and want to thank the ocular melanoma specialists that I consulted, Dr. Barrett Hike and Matthew Wilson of the Hamilton Eye Clinic at the University of Tennessee, where I received my treatment, Dr. Dan Gombos here at the University of Texas's MD Anderson Cancer Center, and Dr. Evangelos Gragudis at Harvard, where the professionals that I consulted. They took time to educate me, and that helped me to choose my treatment. I'm grateful for the initial diagnosis and the continuing follow-up by my local ophthalmologists, Dr. Leon Lahaye and retina specialist Dr. Robert Blem. I appreciate those on Caring Bridge also who shared their experiences with this particular cancer. Their very survival gives me hope and gives me encouragement that I can deal with it and beat it. And most of all, I appreciate my husband and my children, my family. I have a huge family, by the way. My immediate family is big, and my greater family is even bigger. So I appreciate them for the extraordinary level of love, care, and support that they've shared with me. You can't walk alone. You can't walk alone. It's just too hard. The theme of this conference is very comforting. Eyes on a cure. Because this is such a rare disease with no known cure, it gives us hope to look forward to one. It's important to support each other, and it's important to support the foundation so that a cure can be found. I think it's a way that we can help ourselves. We'll all be better off for this work. You know, I told my doctor just before my treatment that with my history of doing really special jobs and dealing with difficult situations, and now with this diagnosis of a rare cancer, I was really tired of being so doggone special. I mean, really. I wanted to be ordinary just for a while. Just let me be ordinary. And he assured me that in his world I was not special at all, that I was just one of the many similar cases his team of caring professionals would try to cure. That was music to my ears. Well, while I was in treatment, my sister sent me a pirate's costume, so of course I put it on. It had a frilly shirt, pantaloons, it had boot covers, a hat and a wig and a sword. It even had a prosthetic hook to go with the eye patch that I had gotten from the hospital. A black one, of course. And it was a pretty funny outfit, and my daughters, I had 2 daughters there at the time, and we were just laughing and cutting up, and so I put that outfit on, and we took an iPhone picture of it, and I sent a picture of, and labeled it Patches the Pirate, to my doctor, and he texted back that, well, since I was actually the first pirate he ever treated, I was special after all. You know, dealing with cancer can be done in many, many ways, but I remember this very elegant Southern lady that I met on the campaign trail. And the first thing after about knowing her 2 minutes was she announced to me, she said, you know, darling, I have cancer. Well, it kind of took me back. It was not what I expected in this kind of meeting. And she said, oh, you know, and I gave her some words of comfort, but she said, not to worry about it, darling. She said, cancer can work miracles for you. She said, especially if you need a table in a restaurant and they say they can't serve you. She said, I just say, listen, honey, I've got cancer. I need a table now. I might not be here next week. So I just want to give you another tool on what you might, you know, find an interest, and let you know that many people handle it in so many good, unique ways. And she lived a lot more years past that visit of mine. With all the doctors, with all the materials, and all the facts that surround you during diagnosis and treatment, the greatest resource we do have is our ability to laugh in the face of cancer. We have to love those who surround us, and we have to learn to live, really live while we have a chance. If we mourn our lives every day, we are missing a chance to live that life. We don't know if we might walk out of here and get hit by a car and wiped out at any moment, and I keep reminding myself of that. We don't have an insurance of how long we're going to live. And you know, you just have to keep your faith strong, keep your faith in yourself, keep your faith in your God. Keep your faith in your ability to enjoy and savor the life that you have. It can be as short or as long, but if it's not a good life, if it's not a thoughtful life, it will be an empty life. So I want to tell you all that I love you. I've had a chance to visit with many of you, not all of you, but many. And you are courageous warriors. God bless all of you, and let's get that cure going. Thank you.
Thank you so much, Governor Blanco. A really inspirational and meaningful speech, I think, on many different levels, I think, for all of us. So can we give one more round of applause to Governor Blanco for sharing so much of yourself with us and for being here. I think we have a few technical things that we need to do over the next 5 minutes, so maybe we'll take a 5-minute break, load some presentations for the next panel, and then reconvene in about 5 minutes. And a reminder, the concurrent session will be next door.
Yes. Hi, how are you?
Good, how are you?
Fine, thank you. And your doctor?
Beadle? I'm the fourth one. Yeah. Okay, I'm good. Thank you, Sara.
You're welcome. You got it? How are you, sir? Okay. Your doctor?
Gupta?
I'm sorry?
Gupta?
Right here?
Yeah. Do you want it to move it over or?
Thank you, sir. Go ahead. How you doing today?
I'm all right. How are
And
you?
you're?
Dr. Tam. Thank you.
You're welcome. Thank you.
Sorry, actually thought.
And so everyone's slides are, yeah, they're all, okay. So, Alda, first. So you're in Boston?
Yeah.
I'm an internist. So, yeah, so I'm in the, I got into this. All right.
Yeah.
We're not.
Okay, I'm gonna start bringing people.
Ready? So we can see everyone else's.
Sure, and then come up. Yeah. Perfect. Yeah. Okay. Okay, I think we're gonna try and get started here. If those of you by the door could maybe let people in the hallway know we're gonna get started, please. And once we're done taking photos. So before we get started on the next panel, I just want to remind everybody that you have your evaluations in your folders. So please fill out the evaluations. You can leave them on the table, the registration table for us. And we're going to be following up with an email evaluation as well. And so hopefully we can capture your input in multiple ways. All right. All right, I think we're going to get started. Thank you all for coming back. And Molly, can you just double check that we have everybody out there? Maybe we'll close the doors and get started. So just a reminder to please fill out your evaluations, leave them on the registration table. And if you have to leave before the afternoon sessions, then we look forward to being in touch with all of you. And if you have questions or interests about ways to get involved and aren't able to stay for the afternoon, then we really look forward to being in touch on an individual level. All right. If I could ask you all to please finish up your conversations so that we can get started, that would be great. All right. Thank you. So I'm really honored to be introducing our panel next. We have 4 really wonderful clinicians from MD Anderson who have volunteered to be here on a Sunday morning to share their expertise with us and to be available for questions and answers. So we have 4 physicians, Dr. Sanjay Gupta, who is an interventional radiologist here at MD Anderson, Dr. Beth Beadle, who's a radiation oncologist here at MD Anderson, Dr. Alda, who's also an interventional radiologist, and Dr. Richard Royal, who is a surgeon at MD Anderson. And each of them is going to share with us a little bit of their expertise on liver-directed therapies and local therapies for metastatic disease. So thank you so much for being here. And we'll hear from all 4 of them and then have time for Q&A at the end. Thank you.
Well, good morning. It's going to be hard to follow Governor Blanco, that's for sure, but you'll have to forgive us too if we use some of the difficult words that Dr. Blanco was mentioning. When we're talking about clinical things, it's easy to lapse into some clinical speak, but we'll try to keep clear on what we're speaking about. And I'm going to talk about surgery and regional therapies, which is a type of surgery for ocular melanoma that spread to the liver. And a little bit of background, we know that ocular melanoma, when it does spread to a distant site, it frequently spreads to the liver. And we can get that out of this collaborative ocular melanoma study, which is a group of studies where we learned quite a bit about ocular melanoma. And we see in those folks who did have metastasis, 93% of the times they got metastasis to the liver. And in fact, a number of people in that study and with ocular melanoma that spreads get metastasis to the liver, and the metastasis eventually replace the liver, and folks die with only metastasis in the liver. So the liver is an important place for us to kind of focus our efforts. Another thing that's very disturbing is that when ocular melanoma does metastasize, the survival is very short. And so at 1 year, 1 out of 5 people who have metastasis are still living. And so that's the number that we're shooting to improve on. Of course, we want to see 100% of people alive at 5 years, but so many times we have to make kind of incremental steps, and that's kind of our starting point. Now, when ocular melanoma metastasizes to the liver, it can sometimes be resected, and resection still remains our best treatment for ocular melanoma that goes to the liver. And you can see here's a number of treatment centers, including MD Anderson, that report on a few number of patients who have ocular melanoma, and the people who have their liver resected tend to live a longer time. So this shows us that in these patients, somewhere between 30 and 36 months after the surgery, 50% of people are still living with their metastasis. But this is the problem. A lot of times when we go to operate, this is what we find. So this might be a tumor that we can see on the CT scan, but there's other small tumors here that riddle the rest of the liver. And that's frequently the case with ocular melanoma, where on a CT scan or on an MRI it looks like a tumor is resectable, but when we get in there and see the disease, there's disease that's dispersed out through the liver that keeps us from being able to resect it. And so before this job, I worked at the National Cancer Institute. We wanted to find a way to treat this type of disease. And we started with an operation that we call an isolated hepatic perfusion. And it was a very complex operation, but the concept was quite simple. We would take the liver and put it on a heart-lung bypass machine, so the liver had its own circulation, so a circulation that was independent from the rest of the body. And that way we could give a high dose of chemotherapy in that heart-lung bypass machine to the liver without giving chemotherapy to the rest of the body. And the idea there is that we could give a dose of chemotherapy that's high enough that it might kill the tumor while not getting the toxicity in the rest of the body. And we performed a number of these operations for different types of diseases, and ocular melanoma was one of those that we focused on. We found for ocular melanoma that it did tend to make people live a longer time, and we found that there was this one group of folks who had a normal LDH who really got quite a benefit out of the peritoneal perfusion, out of the liver perfusion. So these were folks who had disease that could not be resected. If they did have disease that could be resected, we were surgeons, we would resect that disease instead of going to the perfusion. But those who could not have it resected and had a normal LDH, this operation turned out to be good at improving survival. But it's a huge operation, and folks took a while to recover from the surgery. It was kind of a monumental surgery to go through. And some patients didn't have the normal quality of life after the surgery that we would want them to see. Now, we've had friends around the world. Here we see some centers in Sweden and in Netherlands. They've been kind of our main partners with this, who looked at this operation also and found kind of similar survival rates after the surgery and found a similar experience to us with respect to the LDH. But this operation wasn't perfect, and so we wanted to find another way to make this treatment simpler. And there was a device that actually people here at MD Anderson were working on. Dr. Wen-Jen Hu, who's one of the medical oncologists here, actually developed this treatment when she was early in her training. And this is something that we're going to call I'm going to call percutaneous hepatic perfusion. The company that works with this device would like us to start calling it chemosaturation. And Steve Curley, who's a surgeon here at Anderson, worked on this device to treat another type of cancer. So both of these groups were working on using this device to treat other kinds of cancers to the liver, and we wanted to develop it for ocular melanoma. It turned out to not be such a good approach for hepatocellular cancer and for colon cancer that's metastatic to the liver. But the idea was the same. We wanted to give a very high dose of chemotherapy to the liver that has the disease from ocular melanoma, while sparing the rest of the body exposure to the chemotherapy, so there would be less toxicity from the chemotherapy. And so we worked with our interventional radiologists and our anesthesiologists, and the interventional radiologist would put a catheter into the artery of the liver so that they could get the blood supply to the liver, the kind of things that Dr. Gupta and Dr. Tam do all the way, an amazing amount of technology to do that. And then they could infuse a high dose of chemotherapy into the liver. And then we use this other device that would then have this specialized catheter that would capture all the blood flow out of the liver, and then we would remove that blood flow that's draining out of the liver that's really rich with chemotherapy and pass it through these filters, and the filters would filter out the chemotherapy. And then we would give back the chemotherapy poor blood to the body so that the rest of the body was not being exposed to that very high dose of chemotherapy. If we do that, we could give a much higher dose of chemotherapy than we could ever give just giving it in the vein. And we found that quite a bit of we use a chemotherapy called Melphalan. There's actually a very narrow number of chemotherapies that can work this way, giving it a one-time shot in a high dose. There's few chemos that can be effective in that kind of a treatment strategy. But we also found that along with removing the chemotherapy, these filters remove a lot of other things that we would like to keep, like adrenaline that keeps our blood pressure up, proteins that help our blood clot and that type of thing. And so the perfusion itself ends up being a little bit stormy because while we're doing this filtering out of the chemo, we're filtering out other things that we would like to have in the body to keep it going. But we found in our first group of patients with ocular melanoma that patients were living longer than they would without the treatment. And this was in a time where we were also doing the liver perfusion trials, the open operation. And so the patients who were on this were a group of patients who were kind of had worse disease, patients who couldn't undergo the open operation. So we designed this trial, which is a trial for folks who had ocular melanoma that was metastatic to the liver, and they were randomized to either have a perfusion with the device that I just described or have best available care. And these folks would get chemotherapy by vein, or they would get one of the liver-directed therapies, and then we'd watch to see when their disease progressed, either disease growing or new sites of disease in the liver or disease outside of the liver. And then people who had gotten the best available care and progressed, we then would do a PHP after that. We would do the percutaneous perfusion after that. We didn't feel that it was quite right to not do the PHP, although that took a little bit of arguing to get that done. So our real measure was, how long would this PHP kind of stave off the progression, because we know staving off the progression in real life translates into a longer survival. Although we knew we wouldn't be able to show a longer survival because everybody got the perfusion eventually. So our study was designed for people to get 6 of these perfusions. In reality, most people only got 4 of these perfusions. As time would go on, it was usually that people's platelet count would start to drop, and so we wouldn't be able to go on to the 5th and 6th, although there were a few patients who got a 5th and 6th perfusion. This was much different than the open operation, where we can only do one time and only do one time in somebody's life. This we can do every month and repeat it. And we have a number of patients who, since then, have needed to have the treatment repeated, and we could repeat it at a distant time. But so we would treat people every 4 weeks, and then check with scans in between and be sure that their disease wasn't progressing. So this is an example of somebody who has very large disease in the liver. These kind of white spots in the liver are the metastasis, and you can see there's quite a bit of metastasis. And then here we are 9 months after the perfusion. This particular patient had 2 of the perfusions, and you can see there's still some residual mass here, although this wasn't growing in size. And what we would often find is that these tumors would revert to a cyst of dead fluid rather than actually going away completely. We did find that some of the tumors would shrink away, and this is kind of our language to talk about when tumors are shrinking. But what we found was that 34% of people had their tumors shrink, 50% or more. This was kind of unique, though, because a lot of the tumors, like I say, would convert to a cystic mass that wouldn't go away and would be the same size as the tumor that was there before. And so we had a large number of people who received 52% who had what we call stable disease, meaning they had a mass there that didn't decrease by at least 50%. And then we found that those people that got the best alternative care, if we then treated them with the PHP, they often would have responses. We see 22% of people had shrinkage of their tumor, and then 41% the tumors didn't grow. And then this plot here shows how folks survived after the trial. And this is survival until they had some tumor growing or new sites of disease. And we see if they had the perfusion, they survived a longer time than if they got all the other cares that we have available right now. And we didn't see an increase in their long-term survival, but like I said, that's because these people here then, once they had this progression, we would tend to perfuse them. If we looked at those people who got a perfusion after their best alternative care, to those who couldn't get a perfusion, these were usually people who had new disease outside of the liver, like in the lung or somewhere else. In fact, that's what all these patients were. Then we would see that they had their survival prolonged. So we still have some work to do. You know, I would say these are still experimental treatments. And the isolated hepatic perfusion, we're looking at ways to change the dose so that the treatment is a little less rough on folks' livers. And we're looking at ways of revising the procedure to make it a shorter operation, because a long operation translates into a long recovery. The percutaneous hepatic perfusion, or chemosaturation as we're supposed to call it now, is approved in Europe. The device is approved for use in Europe, and folks are starting to use it in Europe, but its use in Europe is falling off a bit for a couple of reasons. The FDA is reviewing the device for use here in the States. It isn't approved yet in the States, and the FDA would really like to see us improve those filters so that it removes more of the chemotherapy and less of the normal proteins, and the revised filters have been developed in the lab, and I found out last week that MD Anderson's going to be one of the centers to test those new filters and see how they work. And all that is going to be to limit the toxicity. So what we know is ocular melanoma often metastasizes to the liver, and some may die with tumors only in the liver, and that whenever possible, we should resect the tumors in the liver. That's still our best liver-directed therapy. People live the longest if we resect the tumors in the liver, but that can rarely be done. Current scanning methods may not catch all the disease that's in the liver, and both isolated hepatic perfusion and percutaneous hepatic perfusion, these regional treatments, are experimental therapies that may prolong survival in metastatic ocular melanoma. I think we're going to kind of go through each of the talks, and then we'll take questions at the end of the talks.
Thank you, and good morning, everybody. I'd like to thank Dr. Selig for giving me this opportunity. Talking about some interventional treatment options available for patients with liver metastatic disease. As Dr. Royal has already mentioned, liver is a very common site of metastatic disease, and 95% patients who do develop metastasis liver will have metastasis in their liver. And survival in these patients, unfortunately, is very poor. As Dr. Royal mentioned, surgery still remains the first-line treatment. However, only 10% of patients are candidates for surgery. And systemic chemo is not very effective in these patients, so that's where we come in with some form of local or regional treatment options. So what are these treatment options? This can be divided into two categories, basically local ablation or catheter-based treatments. The local ablation, basically we place the needle directly into the tumor, to the skin, and then we deliver some sort of heat to kill the tumor. These are called thermal ablation. The two common energy sources that we use are radiofrequency ablation and more recently microwave ablation. In catheter-based technique, basically we take a small tube up your vessel and go up to the liver and find the vessel which is supplying the tumor and then inject anti-cancer agent. These can be various like chemoembolization, immunoembolization, but chemoembolization still remains the most common treatment in this group. So which patients are suitable for local ablation versus catheter? If you have 3 to 4 lesions and each lesion is small, less than 3 centimeters in size, then we can use an ablative technique. However, if you have number of lesions distributed in both lobes of the liver, then catheter-based techniques are more suitable. Sometimes we combine the two, specifically if you have a small number of lesions, however, one of the lesion is measuring more than 3 centimeters in size, and we know that local ablation alone will not work, then we can combine ablation with chemoembolization. So what is chemoembolization? Basically, we combine chemotherapy along with small particles that we inject into the vessels supplying the tumor to shut off the blood supply to the tumor. So what it does is, because you're cutting off the blood supply to the tumor does not get any oxygen and nutrients, so it slowly dies over a period of time. In addition, we are injecting chemotherapeutic agents, so it's a double punch kind of thing. Hypoxia combined with chemo. Basically, it's usually performed with local anesthesia, a little bit of conscious sedation. Again, as I said, we inject a small catheter from the groin and go up the blood vessels and go to the liver, and this is done under real-time guidance, so we know where we're going. We inject some dye to visualize the blood vessels. And once we get there, there's a small catheter which is in the vessel supplying the tumor, and then we inject these particles along with the chemotherapeutic agent, and it results in shrinking of the tumor over a period of time. So various chemotherapeutic agents can be used. The most commonly used agents have been cisplatin, mitomycin, and also doxorubicin. And again, various particles can be used. PV embospheres are the most commonly used particles. Iodized oil is another agent which can be used, which is also embolic and also carries a chemotherapeutic agent preferentially to the tumor. Recently, there have been development of new kind of particles which they soak up the chemotherapy and then they slowly release the chemotherapy over a period of time. Since they slowly release the chemo in the tumor, you're prolonging the contact time between the chemotherapeutic agent and the tumor cells, resulting in an increased tumor cell death. Unfortunately, only 2 different agents have so far been loaded on these beads, doxorubicin and irinotecan, which are more suitable for some other kind of cancer, but also been used in melanoma. And the reason we can do this in liver safely without causing significant damage to the liver is because the liver, unlike other organs, has a dual blood supply. So you have this, the hepatic arteries, which are shown in red here, which supply predominantly the tumor. So most of the tumors get their blood supply from the hepatic artery. And this blue-colored structure is a portal vein, which supplies a normal liver. So even if you shut off the entire hepatic artery, the normal liver will still be perfused the portal vein, so will not be causing significant damage to the portal vein. Unfortunately, not all patients are suitable for this kind of treatment. If the portal vein is completely blocked, as I said, the portal vein supplies a normal liver. I'm sorry. So if your portal vein is blocked, then we cannot completely shut off the hepatic arteries. In those cases, again, these are relative contraindication. Does not completely preclude you from getting this treatment, however, it will not be very aggressive. Similarly, if your liver is already failing, if your liver functions are abnormal, then you have to be careful when using this treatment. Just to show an example, if the technique depends on the location, the number, and the size of the lesions. If you have a single lesion, then we try to go as selective as possible. This is a catheter which is placed in the artery supplying the liver. And then we place a very small catheter which goes inside the bigger catheter and go as far out as possible and then do the chemoembolization. Again, trying to treat the tumor without causing significant damage to the normal liver. However, there are situations like this in which your entire liver has tumors all over, and then obviously we cannot be very selective. Angiogram shows multiple tumors. In this case, we'll do the chemoembolization from a more proximal area, trying to treat the entire liver. When we're treating the entire liver, we try to do one lobe of the liver at one session. If you treat the entire liver, the risk is you will develop more complications or even go into liver failure. And we usually give 4 to 6 week time interval between 2 treatments. So with that kind of disease, you will need 4 sessions separated by 4 weeks each to treat the entire liver. Most of the time, you will have some degree of some symptoms from the liver treatment, like fever, pain, right upper quadrant pain, or some nausea, or lethargy, which usually lasts for a few hours, a few days. The serious complications are liver failure, abscess formation in the liver, or inflammation in the gallbladder requiring surgery are extremely uncommon, seen in less than 1% of the patients. Just show an example. This is a single lesion, was treated with one session of chemoembolization of cisplatin and PVA particles, and this is after treatment. As you can see, there's a decrease in size of tumor, as well as you see it looks blacker. That means the tumor cells are dying off. And another example in which you have multiple lesions in both lobes, and they're treated with 4 different sessions, 2 for the left liver and 2 for the right liver. And then after treatment, you see different decrease in size of all the tumors. The white thing that you're seeing is because the oil that we inject along with the chemo appears white on CAT scan. So this is showing shrinkage of tumor over a period of time. Recently, we have started using drug-eluting beads. An example of a patient, the single lesion here, was treated with drug-eluting beads, and you can see it appears larger, but it's not appearing white as before. That means it's showing the tumor cells are dying off. So sometimes you see the persistent sort of cavity in the area of the tumor. But as long as we do not see any enhancement, that means the tumor is dead. So how often this works, if you look at the literature over a period of 20-25 years, the initial studies all were reported from MD Anderson because this is where this treatment was developed. The response rate varies from 20 to 50% in different series. Average is about 1/3 of the patients will show some tumor response to this. And interestingly, the patients who do respond survive longer. The patients then do not respond, obviously, and the survival can be in the range of about 14 to 22 months. As I said, drug-eluting beads have been used recently. However, the literature is very limited and we don't have much experience with that. The 2 different agents, irinotecan and doxorubicin, have been used in a small group of patients. Partial response was seen in all these patients, but we need to carry on more studies to see whether there's an effect on survival or not. Another interesting method of chemoembolization is called immune embolization. Instead of chemotherapeutic agent, you give a different agent which is called GM-CSF. Basically, it's an immunological stimulant, and we give directly in the tumor. It results in stimulation of the immunity, and that can cause some anti-cancer effect on tumors present elsewhere in the body. Again, very few people have used it, and some preliminary studies do suggest that immunoembolization may have result in a better survival in selected patients as compared to chemoembolization. However, patients in which chemoembolization is not safe because of the things I mentioned before, like your portal vein is occluded or liver function is failing. In this case, we cannot do the embolic component, but we can still do the local chemotherapy. We just take a catheter up into the liver, just infuse the chemotherapy. However, it's not as effective as chemoembolization because we're using only chemo and no ischemia. And you have to do multiple treatments over a period of time, separated by 3 to 4 weeks in between treatments. There are only a few studies with these, and they have reported a response rate varying from 5% to 38%. Another recent treatment is radioembolization, in which, again, very similar. You take a catheter up into the liver, but instead of chemo therapeutic agent, you inject small particles which have radioactivity, so they slowly emit radiation from inside. So instead of external radiation, you're radiating the tumors from inside. So the particles which are used, they are called search spheres or thermospheres, and they slowly emit radiation over a period of time, which lasts for about a month, and they kill the tumor from inside. The 2 agents which are available are thermospheres and search spheres. Unlike chemoembolization, these spheres, if they go to an areas outside the liver, they can slowly emit radiation and cause complications. So especially if we look for 2 different areas, there's GI tract, there's your stomach and duodenum and lung. So we inject a surrogate initially, which is called MAA, which is they have a similar size as the radioactive spheres, and you see where the radioactivity is seen. This is what you want to see. most of the activity in the liver, nothing in the lung or the GI tract. If you see a lot of activity in the lung, which is more than 20% based on calculation, then there's a chance that your lung can be damaged by the radiation. You can get radiation fibrosis. So those are patients who are not eligible for this kind of treatment. And if you see a lot of activity in GI tract, again, you have to be careful in injecting these particles. So if you see a lot of activity in the GI tract, what we do is try to block off those blood vessels. As you can see here, these are the liver tumors, liver blood vessels, and this blood vessel is going towards your stomach and duodenum. And we do not want to inject the radioactive particles here. So we'll take a very small tube up there and inject a number of coils to block off the blood supply. So when we inject the radioactive particles, they will not go into the GI tract and go only in the liver. Fortunately, the GI tract has blood vessel supply from other sources, so will not cause any damage to the stomach or duodenum. Just show an example of how it's done. The catheter is going from the groin up the liver, and then we inject these radioactive particles through the catheter. The side effects are generally minimal. You will have a little bit of lethargy, which can last for about a week. The risk of major liver toxicity is very low, and this is done as an outpatient procedure. You don't need to be admitted for the procedure. Unfortunately, we don't have much experience or use of this treatment in melanoma. There was one study in 2006 in which multiple tumor types were treated. Only 2 of these patients melanoma, both showed complete tumor necrosis on follow-up imaging. Some recent studies have shown that you can get a response rate as high as 63% using radioembolization. Dr. Royal has already covered this part, so I will not go over this. Moving on to local treatments, as I said, thermal ablation, radiofrequency, or microwave are the 2 commonly used techniques. Basically, different kind of needles are available which can be directly put in the liver. Just show an example. This is a tumor in the liver, needle going in the liver. It is connected to the generator and the grounding pads to complete the circuit, and then we heat the tumor, allowing it to die over a period of time. Depending on the size, we can do either a single ablation. The idea is to kill the tumor as well as an area of normal liver around it, because there may be some microscopic cells around the tumor. If it's a big tumor, we have to do multiple overlapping ablations to cover the entire tumor. And this we do with real-time guidance using either ultrasound or CT, or sometimes a combination of both, showing a probe within the tumor. Again, literature is very limited, experience very limited with use of ablation for melanoma. In one study, they showed 1 year survival, disease-free survival about 60%, or 3-year survival is in the range of about 38%, and the median overall survival is about 26 months. Just show an example, patient with 2 different liver lesions, one on the left side and the right side. This was a small lesion, as I said, was treated with ablation alone. However, this lesion was about 3.5 centimeters. As I said, if the lesion is too large, ablation alone may not work. So we used a combination treatment, and 2 years later, the disease is under control. I mean, this area looks larger. This is just an ablation effect, not actually the tumor. So to conclude, a number of minimally invasive treatment options are available for patients who are not surgical candidates and with liver lesions. And in selected patients, these can induce response and result in improved survival. Thank you very much.
Well, thank you for inviting me to your conference today. I'm Alda. I'm another interventional radiologist, and I work with Sanjay Gupta. Hopefully from his talk you see that it's an exciting time to be an interventional radiologist in oncology, because we have a lot of toys that we can play with and tailor to help cancer patients achieve local regional control in different organ areas. And so he talked a lot about the liver. My job today is to sort of run you through our options for controlling disease beyond the liver, primarily the lung and the bone. So we're going to cover how we do it, why we do it, whom we do it in, I guess, and just briefly conclusions. So Sanjay's already mentioned a lot about our thermal ablation techniques. For areas in the lung and bone, we primarily use radiofrequency ablation and cryoablation, and we also have the option here at MD Anderson of doing laser ablation. And the principle of thermal ablation is to either heat or freeze the tumor until you kill it. So it doesn't really matter what modality you use as long as you choose the right technique that will allow you to achieve that goal. Oh, sure. Is that better? Is that better? I'm not sure this is better. Is it better? No. I know, I've never been mic'd before. Well, he may have to adjust it. Oh, that's better? Okay. There you go. All right. So moving on, how do we burn, freeze, or laser the tumor? So the radiofrequency ablation, we turn the patient into an electrical circuit, and you burn the tumor. In the laser, you put in a fiber, and you also heat the tumor. In cryoablation, you use some physical property called the Thomson-Joule effect, and so you put a probe into the tumor, and you run pressurized argon to create ice, and then pressurized helium to melt that ice. And what we see here is a tumor in the acetabulum, or the hip of a patient, and the arrow is pointing at this dark area, which is the ice ball, which is starting to form. So what we want to do is create an ice ball that's large enough to cover the tumor. And the reason why a lot of people use this, those of us who do a lot of bone work, is that it's a natural anesthetic, so it's less painful than if we were to burn your tumor. You can see the ice on the CT scan, so that lets us be more careful in, one, getting the ice all around the tumor and also avoiding any critical structure that may be adjacent to your tumor. It is pretty predictable how fast the ice will grow. And then for people with renal cell carcinoma or kidney cancer and melanoma, where there is thought to be an immune component to the disease, cryoablation, and this is controversial, has been thought to potentially be able to stimulate the immune system. So the advantage of laser ablation is that it creates a very focal heat area, and it's compatible with MRI, so it makes it better for areas in which you have really big critical structures that you want to avoid. So this is basically a spinal body, and this white lesion here is the melanoma tumor within the spinal body. You want to be able to kill this tumor without damaging the spinal cord, which is here in the center, or the exiting nerve root that either controls sensation to your ribs or maybe controls motor down your leg. So in this case, with laser, you can put a probe into the tumor and at the same time use various MRI physics sequence that I'm not an expert in, but basically you monitor the temperature in the areas that you don't want to damage, the spinal cord or the nerve, and you can create a very tailored zone of ablation to target solely the tumor. So why do we do it? There are two primary indications of why a patient may come to see us for consideration of thermal ablation. And the first is if you have pain. If you have pain that isn't controlled by medication, or you've been through radiation and your pain has come back, you may come to see us for one of these ablation procedures to get rid of your bone pain. The second, and this is kind of an exciting area that is emerging slowly in people that do a lot of bone and soft tissue ablation, is that we found that if you have a lesion that's suitable in the lung or the bone, we can potentially use these ablation techniques to control that area of disease. So looking at how it helps with pain. If you burn or freeze the tumor, it will destroy the nerve fibers that supply the bone lining, which causes pain. It'll decompress the tumor volume, and it'll destroy the tumor cells that produce factors that can stimulate the pain mechanism. It also decreases osteoclast activity, which means you form new bone, can also cause you pain. And the goal is really not to get rid of all the tumor, but to target where the tumor and the bone meet each other. So in patients that have pain, it doesn't necessarily matter how big the tumor is. We can still achieve a generally good result for this indication. And so there have been several large prospective trials that we've participated in and that have been published. And what this states is that people who came in with worst pain of around 8 after undergoing one of these thermal ablation procedures for pain control, they dropped off to, roughly about 4.5. So generally, on average, you have a 2-point drop in worst pain. And it doesn't matter if you do radiofrequency ablation or cryoablation. Statistically, they both provide the same pain relief. And this is another study that was published recently in Cancer, also indicating that after ablation, the pain scores go down by time point, relief scores go up, and patients' moods and also sort of the patient description of the severity of the pain, the mood goes up and the description of the severity goes down. So, thermal ablation is a well-accepted way of dealing with bone pain from metastatic disease. And so this is sort of the more emerging part of thermal ablation and using it to control local disease. So oligometastatic disease in the lung, soft tissue, or bone. And the logic behind this really goes back to the surgical studies that they've done. And if you look at cancer patients with lung metastases in which they've subsequently gone on to surgery and they've cut out all the lung metastasis, it actually improves their 5-year survival. So if you do that for a patient, the 5-year survival is 36% versus if you don't complete the resection of the lung nodules or you don't cut it out, the rate is about 13%. So if you extrapolate that to what we can provide, if you are able to completely burn or freeze all the lesions, then theoretically you should also be able to control the disease and hopefully extend survival. And the data in this field is really new. So what we have are emerging studies, because if you look at this, they've only just been published since 2012 and this year, of people that have done retrospective chart reviews of their records. So they've looked at all the patients that they've treated and they've come out and with case reports saying, look, this works. So it's a proof of principle. And although none of these studies are isolated solely to melanoma, there are melanoma patients in 2 of these trials. And the other one that we see a lot of bone disease in is renal cell cancer. So, I think the research is coming, and as long as the patients are selected correctly, I think that this is a viable option for patients with limited disease. So these are just a few case examples. I know this is not melanoma, but this is a patient with a metastatic leiomyosarcoma. So it's a sarcoma-type tumor, and she had an isolated metastasis to her right breast. Unfortunately, to treat this very small lesion, it would have meant that she would have had to undergo a mastectomy. And she was 72 and she didn't want to do that. So what we did was we put the cryoablation probe through the lesion and we froze it under ultrasound and CT. And we used some warm saline to protect the skin so you wouldn't get frostbite. And what we have down here is you see the natural evolution. So she had this in June of 2010. In August, it looks kind of fuzzy, but fairly the same size. And you follow it all the way to 2012, and you see that it gradually involutes. So again, we're looking at very small disease that you can completely cover using this type of method. And that sort of is one of the limiting factors that we can't treat widespread stuff. You have to have very limited volume disease. This is another case of a patient with renal cell cancer. This was a solitary rib metastasis. So here we're using cryoablation. You see the ice ball, that black line is where the probe was, and there's ice around that. We froze that, and 1 year later, all the changes have involuted, and he remained without evidence of disease. This is actually a melanoma patient, so it's a cutaneous melanoma, not an ocular melanoma, but this man, has been through a lot of treatment. So he was first diagnosed in 2005 in the neck. He was resected. He developed brain and lung metastasis, which were resected. He developed metastasis to the liver, lymph nodes, clavicle, and bowel in 2008, and he was started on systemic therapy, including high-dose IL-2 therapy given in 2010. And he came to us because he had a right clavicle lesion that was causing him pain and limiting his range of motion and activity. This had been previously radiated, for which he got some relief, but then subsequently the pain came back and he thought it was pretty unbearable. So we did a radiofrequency ablation, or sorry, this is actually a cryoablation. So probe in the area, create the ice, protect the skin. And this was done in 2010. 3 years later, this area remains not active on PET-CT, so all the tumor has been killed, and he is also pain-free. So who are we looking for? We're looking for patients who are high risk for surgery, tumors that are radio-resistant, so melanoma or renal cell cancer, and your tumor factor has to fit in within size, number, and location criteria. So there are some sites which are not good for this type of therapy. If you have pain, we're looking primarily for lytic lesions, so where there's holes in the bone. And again, radio-resistant tumors. You can't have the tumor in contact with bowel or the spinal cord or things that would make it dangerous to undergo the procedure. So if you were to have a procedure here at MD Anderson, we see you in the clinic, we talk about what we're going to do, we go over your images. The day of the procedure, the procedure is usually done with anesthesia support under CT or MRI guidance, and we either burn or freeze or laser the tumor. And then we follow you up on imaging. And the imaging is quite intensive because we want to make sure that we have treated all the tumor and to catch tumor early if you need another retreatment, because these thermal ablation procedures tend to be repeatable. So in conclusion, again, we have a lot of toys, image-guided techniques that exist or are emerging for the palliation of painful bone metastasis. These are viable alternatives for patients who have failed conventional treatment. I think the patient has to be selected very stringently, just so that you are able to give prognostic information as the operator. And I think that really the future research into the use of ablation techniques for local disease control or oligometastasis is warranted, and it's coming. So that should be another option that becomes more established in the future. Thank you.
All right. Good morning, everyone. Thank you so much for the invitation to come speak. I'm a radiation oncologist. I work here. I do all of the ocular brachytherapy, so all of the radioactive implants. And today I'm going to talk a little bit about that and also radiation therapy for the metastatic ocular melanoma. So as all of us know, uveal melanoma is the most common primary intraocular malignancy in adults, and it affects many of the people we love. Of all the melanoma cases in the U.S., only 5% develop in the ocular or adnexal structure, so structures surrounding the eye, and 85% of these are uveal in origin. And looking at the population in the United States, you can see that there are only between 3 and 8 cases per million of population, and this is showing the variation in rates of disease from 1973 to 2007. So as Governor Blanco noted, it is a rare disease, but it is an important disease. So local therapy for ocular melanoma, I know we've discussed at length. Surgical options include enucleation, or now we can offer radiation therapy. And radiation can be delivered really to the eye in 2 ways. One is with plaque brachytherapy, so a radioactive implant. These are just a look at some of the common implants here, where we have a gold plaque here. There's an insert where we order radioactive seeds that can go into this plaque, and that is sewed in place with the help of an ophthalmologist and a radiation oncologist. This is in place for the duration of approximately 5 days and then removed. It gives a very high dose of radiation to a very small area. External beam radiation therapy, specifically with protons or carbon or helium particles, has also been studied and is well studied. It's available at a very few number of institutions throughout the world, and also is allowing us to treat ocular melanomas locally with radiation therapy. Again, the technique using particle therapy is to give a small area a high dose of radiation and give us cure in that location. There have been multiple well-designed and well-executed trials that have established the standard of care for localized ocular melanoma. Namely, the Collaborative Ocular Melanoma Study, or the COM studies, have shown us what is appropriate in small lesions, medium lesions, and large lesions. And many of our practices have changed with the findings of that in medium lesions, where patients were randomized between enucleation or brachytherapy. And with over 1,000 patients enrolled, again, really remarkable in a rare disease, there was no difference in survival at 12 years with radiation therapy, proving that not every patient needs to have their eye removed, and that radiation therapy alone is effective treatment for this disease in the eye. But how does radiation work? Radiation induces a biochemical response. So a radioactive beam, either from a decay of a radioactive element or a large machine, makes a high energy beam that then goes in, and a photon goes and causes DNA damage. So it doesn't really burn it or zap it or microwave it or anything like that. It actually causes a biological damage to the DNA. It causes a break in the DNA of the tumor cells. And that infliction of damage is a physicochemical process. And then your body deals with it. So it processes that damage. And when the cells note that there's this really disparate change in the DNA, it goes through a biological death pathway and the cells die. So this is why radiation therapy is very effective. It causes damage to the DNA of the cancer cells, and when they go to make new cancer cells, they realize there's an error and they die. However, it's important to note that your tissues have DNA too, and it's the same DNA. So that's where the side effects of radiation therapy come from, and why it's very important to give radiation to as limited an area as possible to maximize the cure and minimize the damage. And as a result, it's very important to note that radiation is a local therapy. It works where we aim it. The side effects occur next to the tumor in the areas that are irradiated. So it's very important to give as high a dose to as small as area as possible. Now, radiation therapy has been shown as, again, to be an effective therapy in the eye. But as we all know, patients with ocular melanoma have a risk of distant disease. And if you hold up the pen that you're taking notes with, the tip of your pen is about a cubic millimeter. That's 1 million cancer cells. No scan that we have can show that. And there's nothing we can do to ensure right now with our best technologies that cells haven't gotten out. So what we need to do is keep working on finding better diagnostic techniques to find this out and to give better rates of cure for those people that have them. Looking at the Collaborative Ocular Melanoma Study group, patients that were assigned to either brachytherapy or enucleation, the rates of death with metastatic disease at 10 years were similar, between 18% versus about 17%. So in that group of patients, some of those teeny tiny cells had already gotten out away from the eye, and even if we effectively treat the eye, they may take up residence somewhere else and ultimately cause disease. What we need to do is figure out how to treat that most effectively. Radiation therapy can be used for metastatic disease in the same way that it's used for local disease. However, for widespread metastatic disease, for more than a few lesions, systemic therapy is the key component. Therapy that goes in the blood vessels and goes everywhere. Because if you have a couple lesions in the liver or the lung or the bone, that suggests that you have many more of those teeny tiny cells throughout the body. So if we aim specifically at one of those lesions with surgery with Dr. Royal or with interventional therapies with Dr. Gupta or Dr. Tam or with my radiation therapy, we're missing the rest of the disease. So we're really no further ahead. However, for localized lesions, radiation therapy can provide benefit. It can provide palliation for patients with multiple lesions, but a large lesion that's causing pain, for instance, in the bone. You can treat that area with radiation therapy, knowing that we aren't treating all of the disease, but trying to provide some benefit to hold that at bay to cause at least temporary relief in pain or progression. For palliative intent, we typically do short course treatments to moderate doses. So common regimens are delivering radiation therapy for approximately 10 days, so 2 weeks of daily treatments. And we typically use somewhat larger fields to lower doses to try again to give some palliation, some improvement in that disease site, but knowing that we're not taking care of everything. Ultimately, we would like to catch these at an earlier stage and provide treatment with curative intent to, like we did in the eye, to completely eradicate the disease at that site. So this is necessary and indicated for isolated single or very small numbers of metastases, 1 or 2 metastases that we don't have evidence of other things. Again, we know that they got there through the bloodstream, so we need to give systemic therapy as well, but we can try to provide curative dose to cure it at that site by giving full dose, high dose radiation therapy, oftentimes in high doses per treatment, to very small fields, really targeting those lesions. Again, radiation can cause normal tissue damage, so it's very important to immobilize this area very quickly so it's not moving around, so we're aiming at what we think we're aiming at, and verifying each day prior to delivering radiation therapy what we're treating. In either scenario, radiation therapy for metastatic disease is typically delivered as external radiation therapy as opposed to a brachytherapy implant like we do for the primary tumors. So how is external beam radiation delivered? In the modern era, it's delivered with a big machine that costs several $1 million called a linear accelerator. So the beam is made here in something called a klystron. It actually is accelerated through a vacuum tube. It's bent, and it comes out the head of a machine as an X-ray here. The shape of the beam that comes out can be targeted or can be shaped by a lead group of leaves called a multi-leaf collimator, and these leaves move in and out in each second. So this is what it looks like. A patient is on a table, and this is the machine. The beam comes out here, and if the patient looks up into this portion here, this is what they see, the shape of the beam. This can move around them and give a small dose of radiation from a variety of angles, so it all adds to a high dose in the center like spotlights on a stage. The patient can be immobilized with a cast or a mold in order to make sure that the area of interest doesn't move. And what also can happen is in the modern era, these little wings on the machine here now can be deployed, and the machine can move around them and actually give a CAT scan every day in that treatment position to verify that what we're treating is exactly what we want to treat each and every day before the beam is on. Another way to deliver radiation therapy is with proton therapy. This is an even more expensive and newer technique. This is a look at a synchrotron. These need very well-developed specialty centers in order to deliver proton therapy. This is a 3-story room here, and you can get an idea. This is a ladder that a person would go up to see how big this is. This accelerates a beam of protons, which are positively charged particles that then swing out here into rooms, and the patient's on tables similar to the linear accelerator in these rooms. Proton therapy delivers radiation somewhat differently than photons, but like 2 different brands of luxury car, not one is better than the other. They are just different things. They're different ways of getting the same thing done, which is delivering high dose of radiation to a small area. The way it works differently is how the radiation therapy is delivered. This is a graph looking at depth in tissue from skin to deeper. And photon radiation therapy drops off like this. Proton radiation goes for a certain amount, and then it stops on a dime. The problem is there's some uncertainty as to where it stops, so we have to put some sort of wiggle room in there as well. So in general, both of them, again, the goal is to deliver radiation to a small area, but they do it somewhat differently, and it really depends on someone skilled in the field to determine what is best for you. One is not uniformly better than the other. Going back to the ways that we would treat with radiation therapy for metastatic disease, again, one option always is if someone is having problems is palliation. Radiation therapy is an effective way at preventing neurologic compromise and also treating pain. The fields depend on the location of the lesions, and for multiple lesions it's often difficult to provide palliation to the liver or the lung because of the normal tissue in the area. The lung and the liver are both very sensitive to radiation therapy, so if there are multiple areas, it is more detrimental than not to treat the whole or half of a liver with radiation or the whole of a lung if there are multiple areas, in which case systemic therapy is favored. However, so for other areas, for instance, the spine or the brain, if there are multiple lesions, We can treat with a fairly low dose of radiation therapy over approximately a 2-week course and deliver radiation therapy in a way that will result in less progression at that site, at least temporarily. So this is a patient that had multiple metastases in the brain. There's a beam that comes in from each side and treats the entirety of the brain to a relatively low dose, and this appears to be effective at controlling the lesions and preventing progression. Of course, we're more interested in curative treatments. So these are for patients with a single or small number of lesions. This can be done at presentation or for patients with an excellent response to systemic therapy for consolidation to make sure that it does not come back in that location. We can deliver high doses in a small number of fractions. Again, if we can keep the patient immobilized, we can plan using a CAT scan or 3-dimensional planning so we get a full volume of disease. We treat very small areas and we verify prior to dose delivery. Excuse me. Options again depend on the location of the metastasis. This is a patient with a metastatic disease in the liver here. This is a patient who was treated with IMRT, which is the linear accelerator photon-based therapy. You can see the colors here are the target. So this is the area of tumor along with an extra margin, again, for those microscopic cells we can't see. And these lines that you see are the dose of radiation coming in from beams from each of these angles. The goal is to get this shaded area covered by what we feel is a curative dose. In this case, 65 gray here to this small area, and then 58 gray to this larger area here. The areas, the streaks that you see here are very, very low doses of radiation that we do not believe will cause side effects in those beam paths. But again, by coming in at a variety of areas, we're able to get a very, very tight distribution here to the area of metastasis that we see in the liver there. We can do the same thing with proton therapy. This is a larger lesion here with proton therapy, and you can see the lines here are the area that are the doses that we're treating. Here again is the tumor itself. We put a margin around it for the microscopic disease, and this whole area is going to 67.5 gray, which is a curative dose. You can see with protons it's falling off with the beam angles, so that 15 gray, which again is considered safe for the rest of the liver, is really not treating the entirety here. So we're able to save a large portion of the liver and treat the disease here. We can do the same thing with isolated lung metastases. This is a teeny tiny little lesion right over the diaphragm in this patient's lung. You can see in the shaded area that's the tumor, and we can give radiation from a variety of angles to get a high dose just to this area there. So this again is with stereotactic radiation. This is delivered in 10 treatments. So in conclusion, I hope I've shown you that radiation therapy is an extremely effective means of controlling local disease. It only works where we aim it, and it's a key component of curative therapy to the eye for primary ocular melanomas. For patients that develop metastatic disease, systemic therapy is first-line treatment because we need to treat the microscopic disease that we can't see and how it got from one place to the other. However, radiation can be used effectively for consolidation to isolated metastases or palliative treatment to relieve pain, prevent neurologic compromise, or delay progression. It's limited by the normal tissues and must be given in a highly targeted way and verified daily. And as systemic therapies improve, local treatments for metastatic disease will become even more important. Radiation therapy is incredibly effective, but it is a good tool at curing cancer, but it is also a weapon. If it is delivered poorly, we can't take it back. You can't have radiation to the same site twice, and we can't remove it once it's delivered. There have been a series of very public bad outcomes with radiation therapy. This is a New York Times article from 2010. And I just note this because, again, everyone needs to be comfortable with their treatment team. But you have to ask questions and be an educated consumer and trust your physicians and know that this is an incredibly advanced technology that needs to be delivered very carefully. Be a partner in your care and trust your doctors and ask them questions. And if they don't feel comfortable with them, get a new doctor. You deserve the best, and you really deserve someone who listens to you and will answer all of your questions. Just like to acknowledge the organizers of this, and specifically Dr. Selig, for being a voice for this disease. I'm privileged to work here in the ocular melanoma group. I think many of you met Dr. Gombos yesterday. He's my partner in crime with the ocular bakery therapy, and he's also my ophthalmologist. He does my screening every year. My partner, Dr. Morrison, also does some of the brachytherapy in our physics team, which is very important for radiation therapy, and Laura Reckner. I want to thank all of the participants in the clinical trials, especially those in the COMS trials. Again, for a very small disease, we have an amazing amount of research, and that's really due to the generosity of these patients. And I want to thank all of you and your families for really leading the charge in all of this. You all deserve a round of applause. So, thank you. You want us up here?
Thank you all so much for all of your really informative talks. We have a few minutes for some questions. If people have questions, please come up to the microphones and we'll do it like we did yesterday.
I have a question. I want to thank the panelists for a very informative presentation. My question is, we want to try to empower ourselves in some way to fight against a disease that is looming out there or perhaps has presented. But how do we, from all of my research, liver cancer is very sneaky. It doesn't give you any symptoms, early symptoms, unless you're in a screening process, as many of us are. You might not even know it exists. But in the event of a metastasis, does it make any difference, or should we be trying to keep or protect our liver and keep it as healthy as possible? And does that give us a better chance, or does when the cancer, when cancer comes in, I mean, it just takes over and it hardly matters? Does diet and consumption of alcohol, for instance, or fatty foods make a difference in an outcome when you are in treatment?
So I'd say, I don't know, is this, can you hear me? Okay. So it is an important thing to kind of maintain a healthy liver, because the liver might be coming up to treatments, and those treatments will depend on the liver recovering after a treatment. And the things that can make a liver less healthy are heavy alcohol use and some toxins that the liver are exposed to. One thing to be careful about is with medications that might be tough on the liver, and it's important to kind of work with your doctor to kind of like gauge the medications so that they're things that are safe for the liver. But both a resection of the liver or liver-directed therapies kind of depend on a healthy liver that can recover from it.
Yeah, question for Dr. Beadle. If I'm pronouncing that correctly, I'm sorry. Is stereotactic radiation appropriate for spine mets, or bone mets on either the C, T, or L spine?
Yes. So stereotactic radiation is a way of giving a high dose of radiation to a very small area in a small course of treatment. And for an isolated metastatic disease, it is appropriate for that. If there's more than one lesion, it's often better to start with a larger field that encompasses multiple lesions. But if there's a specific lesion, it's an excellent way of getting a high dose to a small area. And also, while we can't get the textbook answers, you can only get radiation to one area once. If you have a larger field and then have progression of a single lesion within the previous treated field, sometimes we have a window to do stereotactic at that point as well.
Okay. And is that usually a shorter course of treatment than traditional radiation?
It is. It's usually a sort of single-digit number of fractions, but it depends on the location and the safety of it. And the goal is to get a very small area and avoid the spinal cord in that, even though it's very close.
Yeah. Thank you.
Thank you all very much. I have two questions. One is quick. Is there an assumption that any one tumor will be surrounded by microtumors? I understand that with the imaging technology, you may not be able to see those. But when you have one isolated tumor, is there an assumption that there are microtumors around it, or just that there may be?
Well, all tumors start as a single cell. And so if it has gotten from your eye to somewhere else, some single cells have gone to that area, and there's no reason to believe they haven't gone to other areas. And then once that cell starts, it then creates a mass that you can see, but it's probably growing in ways that you can't anticipate along the edge as well. So while we can see what we can see, which is a mass, that most likely there are single cells nearby that area as well. So all of our treatments, all local therapies, try to treat what we see and then a margin around it, including surgery and the interventional therapies as well.
All right. Thank you. My second question was that I was thinking about what one of the doctors said yesterday about your immune system being able to deal with these things up to a certain point. When one of you was talking about even if you have several tumors, being able to zap maybe a few of them, is it true that your immune system now will be able to work more effectively on what's left? I mean, even if you can't get them all, if you can get some, are you giving is it just a wishful thinking that you're giving your immune system a chance to work on the others?
I think that you may be referring to the cryoablation stimulating the immune system, and I think that that's been shown in animal and mouse studies, but human beings aren't mice. So while it's a promising sort of avenue to develop and work towards in the future, I would be hesitant to say that if we zap one tumor, it's going to sort of have a mothership effect on all the other, type of tumors.
Okay.
So there are things that have been reported that cryoablation does have effects on the immune system, but I wouldn't say that anything is proven.
Okay, so for multiple tumors, you're still looking first at systemic therapies, and then if that's not indicated, then you're looking at going to individual tumors.
Correct.
Okay.
So
right.
usually, I can only speak for Sanjay and myself with the interventionalists, is that at MD Anderson, everything is done in a multidisciplinary approach. So we are definitely working with your medical oncologist who will be prescribing the systemic therapies. And if you are an appropriate candidate, so in the sense that the systemic therapy has controlled the other sites of disease and you have something in your liver that is growing, or you have something in your soft tissue or bone that's growing that's not well controlled, then that's when you would meet us. So you would never meet us in isolation. It's always done as a team approach.
All right. Many thanks. Many thanks.
Can I just follow up on that question and ask you a question? So for people who aren't at MD Anderson for care, just kind of following up on that, we heard a lot about systemic therapies yesterday. So do you have advice for people on how to what questions to ask if they're not in an institution like MD Anderson where an interdisciplinary team already exists? What questions can people be asking their medical oncologist, for example, how to integrate some of your therapies with systemic treatments?
I think one thing that's always important when you have a rare tumor is to find folks who work with that tumor, and that's always very hard to do. You know, a lot of times you'll be in a center and the team might say, boy, we've never seen anybody with this disease before, but we would like to try this treatment. I think that that's something to probably step back from. You know, it's easier to get treatment that's 50 miles down the road, and it's easier to get treatment that's close to home, but when you have a rare tumor, you really need to seek out folks who say, oh, yeah, I've been seeing this for 20 years, and I know just what your story is, and I've heard it 100 times before. That's the most important thing, I think, as far as finding somebody to treat this type of disease. So I think the thing to ask the team is, how many of these have you treated before, and how many folks have you seen before with this particular kind of expression of my disease?
Thank you. Maybe time for one more question?
Yes, I just wanted to expand on Nancy's question about the immune system. You're the radiation people, and a number of us are on taking treatments that stimulate the immune system, immunology, like ipilimumab and immunoembolizations. There's been some intriguing isolated reports that when you have radiation, that to a single spot, that somehow stimulates the immune system. I think it's called the abscopal effect. Do you have any evidence of that?
It's still an area of active endeavor. So again, as Alda mentioned, that there is some evidence in animal models and things, if you irradiate one area, if you irradiate a mouse that has a tiny tumor on one leg and a tiny tumor on the other leg, you only do one, that there's a response to the second one. But it's probably not complete. So, but we don't know how much leverage we get from that right now, and we don't give radiation therapy to one area hoping to get response in another. So fundamentally, if you want response from radiation, you have to irradiate that spot right now. So the rest of it is is somewhat unclear. It's promising, but I don't think will ever be complete. So we can never depend on radiation to one area to control another. How much it affects the immune system is still an area of active investigation.
All right, thank you very much. Can we give our panel a round of applause again? Thank you so much for your time. All right, we're going to take about a 12-minute break, and then we'll meet back here to go break off into our groups again. The social workers will meet us back in this room. Thank you.
Sure,
She's just right here.
You bet.
Yeah.
You bet.
Okay. I don't know if she minds. I'm thinking.
No, that's fine. That's fine.
Thank you. Thank you for coming. Actually, I have little things. Bring them up. There's just a small token, but I meant.
He's got that budget. He's got it under control. Yeah, I'm sure there's a false front there somewhere. I love that guy. They lowered the boat. Hanging out with the water. Up, down.
All right. Okay, I think for those of us who are left, we're going to break up into our small groups again. Pardon? Same ones. So if we can, I think if we can pull people in and we have the social workers in the back, so maybe, should we start over here? So patients with metastatic disease over here in the corner. And then who do we have next? Is this primary disease? Yes. Patients with primary disease right over here. Yes. And then people who've lost a loved one right here. And caregivers, friends, and family over here. Spouses and partners over here. And then we're going to reconvene after the small groups, and we'll have a chat about a scientific update and getting involved over lunch. So we'll see you all back here at 12:30. Yeah. Okay, okay. So why don't we do that? answer them in session. After
that. We heard early on by other patients that we were talking to.
So we learned that pretty quick, but they
Yeah.
failed. Other students said, oh, I had never heard that one. So they start texting us like maybe only an hour after our appointment. We'll be like, we're still in the room waiting to see Dr. Selig. We'll call you. And that's why I told Jeff, that's why we work with friends. No, let them. I know. So let's see how
most of my family's Catholic, actually. So, yeah, well, my dad's mother was an Italian Catholic, the 7 brothers and sisters. So,
My whole family was Catholic.
so we've got Catholics, Jews, we have a Muslim, every walk of life. That's great. It's very possible.
It's all coming
Jesuits,
back, it's not like, and so, you know, 14 months has passed. And I appreciate it for the afternoon, but and the good people.
never wants me to go. She wants me to keep her. But I still. The goal is to they want to away, to go away, forgive us, we're like brothers, or one of our actual brothers. Like, no, we don't go away.
That was great. That was great.
Because when my daughter was pregnant with my first grandbaby girl, I jokingly said, and so I was looking through a baby name book, and plus I'm bringing out the investigation program. It was so good. I know. And we always see there, one of the foundations. So, it's tough for her. And I said, well, that's it, right there, the door, better. So, today, yes, yeah, she's so happy that, I have never done it in college. Oh, I know they're like, oh, they're, you know, yeah. Oh, you got to meditate. I did either at 5 o'clock yesterday. Yeah, I am. You know, while there I wasn't. All right. Yeah, Robbie. I'm basically go back to buildings.
I just wanted to make sure. It was still going.
I know, I heard some.
magic USB port here somewhere. So I can actually just run it out of this, can't I?
I'm sorry?
I can just run it out of, off this
Off the drive?
drive.
If you want to.
How do I find it though?
Okay, let me help you.
Yeah, okay. Oh, I see, I can do it here. Here we go. Disk. Okay, good deal. There we go. That was easy. Great.
there's a flash drive here. Oh, it stops? Okay. All right.
You doing okay?
How are you doing? Actually, is this someone's? Can I have this? Is that closed? Oh, good. Okay. All right. Okay, perfect, perfect. Okay, thanks. All right. I kind of want to be sitting down at the tables with all of you. While you guys are all eating lunch, we'll use the last hour that we have together to kind of give some MRF and CureOM updates. This is just a real informal time that we have. Whoa. Okay, thank you. So we wanted to take the last hour of the meeting here to give you some exciting updates on what's been going on the past year. We've sort of alluded to some of it throughout the meeting, and then also talk about ways that you all can get involved and we can all get involved as a community to really be pushing things forward. And so I wanted to highlight a few things that the Melanoma Research Foundation has going on in the research and scientific arena. And I want the next hour just to be real informal, and if I didn't have to be at a podium with two big slide projectors, I wouldn't be. So please ask questions along the way, interrupt at any point, but we can also do questions at the end of my talk, and then Tim's going to come up to kind of close the meeting, talking about how we move forward from here. So I just wanted to highlight a few things that you have in your folders. The Melanoma Research Foundation has been really active in the melanoma research arena for many, many years. And Tim talked about the MRF's history in giving out research grants a little bit yesterday. And I just wanted to highlight that in your folders you have the 2012 research awards that have been given out. And so you have abstracts of the different awards that have been given out MRF-wide. And then because the CureOM research grants were given out on a little bit of a different cycle this first year, they'll all be given out on the same cycle this next year, you have CureOM-specific research grants on a separate piece of paper, although there is some uveal work that was supported in the mainstream MRF grants as well. And then something that I'm not going to talk about much today, but I can answer some questions, Tim can answer probably questions better, is the MRF Breakthrough Consortium. And you have a brochure about that in your folders as well. And this is an arm of the Melanoma Research Foundation that was really started to help move clinical trials forward faster in a way that would help focus on combination therapy. And the Breakthrough Consortium is doing a lot of really innovative work. And I just wanted you all to be aware of this arm of the MRF. And the CureOM Research Initiative is working really closely with this part of the MRF. We're all one organization and working very closely to support each other's work and not duplicate efforts, but build on efforts. So if you have more questions about either of these things, we can talk about that as well. So I don't have many slides, but I just wanted to go into a little more depth about CureOM's scientific initiative and introduce you again to our scientific steering committee, give an overview of the research grants that we've given out, give you an update from research meetings that we've had this year, give you a little overview of some outcomes and where we're heading from here. And so I wanted to remind you of the first part of CureOM's mission, which is to support research and accelerate the development of effective treatments and ultimately a cure for ocular melanoma through innovative strategies, including international and interdisciplinary collaborations. And so that's the part of our mission that I'm really focusing on in this update today. And I just also wanted to remind us, again, back to the patient perspective, a couple quotes from Greg, my husband, that I think are the foundation of this part of our mission. So this is Greg speaking. "I feel so energized about the possibilities that can be achieved through collaboration. And as hopeful as I was a year ago, I continue to be equally as hopeful now, not only for myself, but also for the new possibilities in the field and for all of us patients." And I think it's really with this focus on collaboration and hope that, that we move forward and that we really push the research agenda forward. So again, I wanted to remind you that we're guided by a wonderful scientific steering committee. Again, this is a rotating body, so this is our initial steering committee, but we look forward to having input from the research community in many different areas and from many different people. Our first committee is made up of 15 members, and as we talked about yesterday, it's interdisciplinary. So we have medical oncologists, ocular oncologists, cancer biologists, dermatologists, and surgical oncologists, and it's very international in nature as well. And this picture is Tim and I with our two co-chairs, with Bill Harbour and Keith Flaherty, at our first scientific meeting back in May. And so I won't, this is really small, you may not even be able to see this. So we don't have to go over these slides in details, but these are the names of all the members of our steering committee, but you can go onto our website to see all the members on curom.org, and if you go to About Us, all of the members of our scientific steering committee are listed there, and all of the institutions that they represent as well. So a little bit about the Curum research grants. As I mentioned yesterday, we are really excited that we have secured $800,000 in our first year for research, specifically for uveal melanoma. This is a big achievement, and it's a huge step in the right direction, but it's a step, and we know we have a long way to go. But this is really a big step. And with this foundation, we have been able to hand out the first two Established Investigator Awards to the people who are on this piece of paper in your folder. So these awards are $200,000 each over 2 years. We received 19 proposals for this first-time award from all over the world. We received proposals from around the US and Europe. And we went through a peer review process. So the way that works is we took our 19 proposals and we had between 2 to 3 experts in the field review each grant in our first round. We then took the top 6 proposals and we had a more selective expert panel read the top 6 and score those, and then we funded from number 1 down as many as we could fund in the order that they were scored. And we were able to fund the top 2, which is amazing, and we're really, really thrilled with the research that we're able to fund this year. But obviously, there's a lot more research to be funded, and so the more funding we have, the more we can, the more awards we can give out. So this was our first cycle, and the recipients should probably have received their first check or will be receiving it very shortly. And we're already on to our next grant cycle. So the next grant cycle is due by May 1st, and the CureOM cycle will now be part of the regular MRF cycle, so it's going to be on target with the rest of the research grants as well. In addition to individual donors who made these research grants possible, we also received a generous donation from Gerbet USA, and they wanted to donate money to honor a physician at Thomas Jefferson University for his work in the uveal melanoma field. And some of you may know Dr. David Eshelman at Thomas Jefferson University. So Gerbet gave money to establish an award in his name, but that research grant is going to go through the same peer review process as our other grants. So just to go over briefly the 2 research grants that we were able to give out this year, and if you have questions about these or want to know more specifics, I can try to answer them, and Scott Woodman has generously come back to be a part of this discussion as well to answer questions that I may not be able to answer. So our first research grant that we've been able to fund is to Dr. Levi Garraway, who's at Dana-Farber Cancer Institute and the Broad Institute, which is a collaboration between MIT and Harvard. And this, again, is a $200,000 award over 2 years. And the title of his proposal is Dissecting Therapeutic Avenues in Uveal Melanoma through Genomic and Functional Studies. So Scott, or Dr. Woodman, referred to Levi's work in his talk yesterday as he was showing sort of the range of possible targets that there could be in the disease. So Levi has a way to really scan for some of those targets to know what we need to be looking at in the field. So his proposal has two aims. One is to perform a comprehensive genome sequencing in a large number of melanoma tumors. So he is collaborating not only with the team here at MD Anderson, but also with the team at Massachusetts Eye and Ear Hospital to get tumor samples. And so we'll be able to really scan a large number of tumors to look for mutations. And also to identify a spectrum of new targets in uveal melanoma that may provide a basis for new drugs and drug combinations. So we're really excited to be funding Levi and his team. They have done really amazing work in the general melanoma field, and I think they're very excited to be able to take some of what they've learned with cutaneous melanoma and now also look at uveal melanoma. So we're thrilled to be able to fund his work. The second research grant that we've been able to give out this year is to John Sondek, who's at the University of North Carolina at Chapel Hill. Again, it's an established investigator award, $200,000 over 2 years. And John Sondek is a little bit different. So he comes from a very basic science background and has spent a career looking at G proteins. And his project is looking at the interdiction of signaling by G-alpha-Q, which is sort of a fancy word for the part of the G protein that's mutated in uveal melanoma, to treat ocular melanoma. And his aims are to measure the interaction of the G protein in the on state with its molecular targets, and then to screen 100,000 small molecules for ones that prevent the mutated protein from communicating with their targets, like Dr. Woodman showed us yesterday in the slide, again, resulting in potential drugs for ocular melanoma. And what's really, I think, exciting about Dr. Sondek's work is that we're bringing in, so here we have Dr. Garraway, who's been in the general field of melanoma, now coming into uveal melanoma. Dr. Sondek hasn't really been in the field of melanoma, so we're bringing in someone new with new expertise and new insight to look at our disease. And I think he's very excited to think about clinical implications of his basic science work. So it's a real thrill to be able to talk with him and to see his work, and we're really hopeful about what may come from this research. So in addition to funding research grants, we also have been hosting research meetings. We had our first meeting in May of 2012. We have followed that up with 2 meetings in November of 2012, one at the Society for Melanoma Research meeting. And then we had another special meeting at Memorial Sloan Kettering Cancer Center, which I'll talk a little bit more about in a minute. We have our next meeting May 3rd at the Fred Hutchinson Cancer Center in Seattle. And our 2 May meetings, we've paired with one of the largest ophthalmology meetings in the world. So we want to make sure that we're targeting meetings where ocular oncologists and medical oncologists are going to make it easier to bring people together so that we're not having sort of a separate meeting and it's hard for people to get there. So we're targeting key meetings in the field of melanoma and ocular melanoma and then bringing people together in an interdisciplinary way. And so the ARVO meeting this year is in Seattle, and so the day before the meeting starts, we're holding our interdisciplinary Cure-OM meeting to bring researchers together in Seattle. And then really exciting, this fall, 2013, we have been asked by the National Cancer Institute to partner with them to co-host a research meeting focused on ocular melanoma at the Society for Melanoma Research, or SMR, meeting in the fall. So we're really thrilled to be partnering with NCI for the first time to co-host that meeting. And then our scientific steering committee we're working with them to set additional dates for our 2013 meetings. So some of the outcomes of our 2012 meetings, and I'll talk about some of these in a little more depth. The development of standardized procedures in preparation to develop a virtual tissue bank. So we heard a little bit about this yesterday from Bita Esmaili, the importance of having tissue. And many centers have tissue, and I think, David, this might have been something that you brought up yesterday. And how do, research at one center who might need tissue, but they don't have the tissue, how do they go about getting that? And so there are different ways to do that, but one of the ways that the research community has suggested to us would be helpful would be to develop a virtual tissue bank. So that's a way that tissue will stay at the individual centers, but we'll be able to help connect people so that people will know where tissue is when they need it for the research. And as part of that, hopefully developing some technology behind it as well, such as a registry and other information that people can connect to the scientific research. So we're in the process of helping to bring that together. And actually the European group is much further ahead than the American group with this. And so we've brought in some of the Europeans to really help us understand how they developed their virtual tissue bank and how we can not only develop one here, but how we can hopefully connect to the European tissue bank as well, which will just make it much stronger. So that covers the first two bullets. Another initiative that's currently going on in the medical community is the development of a clinical trials network. And again, this is an international collaboration, and it's a group of physicians across Europe and the United States. And we've been involved with the development of this organized group and are trying to help push it forward and help it continue to be more organized. And this will be a way that we can push out clinical trials much faster. And as we know with rare diseases, numbers is a problem. And so if we have a clinical trials network and we push out a trial that's multi-center, we'll be able to get results much faster. And so this is something that's high on the priority list that we're really working on, and we'll be following up in May at our scientific meeting in Seattle. Again, always trying to facilitate and help better collaboration between different research centers. And then these last 2 points. So one, successful discussion for development of treatment guidelines. So the meeting that I mentioned to you that we had in New York that was a little bit special was a meeting that we brought together 20-some of the top experts in the field, clinicians, and we focused more on the clinical component of ocular melanoma. And I think we've all been frustrated in many different ways and many different times at the lack of clinical guidelines in this field. There are a lot of fields who deal with this. We're not alone in that. But this is something that we feel is very important, and we hear from you is very important. And so we are working to help build some consensus in the field about treatment guidelines at each point of treatment. And as we've heard from every panel that's come up here over the course of this retreat, it's not easy, and there aren't definitive answers. And so we don't expect at the end of this process, which is an ongoing process, and hopefully we'll be publishing these guidelines in the coming year, we're not going to have maybe as definitive of guidelines as we all might like, but we'll have some sort of broad stroke consensus that I think will help us move in the right direction. But as we hear from everybody, it's not going to be one target or an easy target, but we're moving in that direction, and the research will help guide us further in that direction. But at least the discussion is started, and it's going. And then the last piece that has come out of the 2012 meetings, I think, is also very exciting on the research front, moving away from the clinical front. And that is a collaboration with the National Cancer Institute's Cancer Genome Atlas project. And just to tell you a little bit about that, it's a project that started in 2009, and it's a $275 million 5-year project. And basically, it's a large-scale collaborative effort to characterize the genomic changes that occur in cancers. The project is co-funded by the National Cancer Institute and the National Human Genome Research Institute. And it involves multiple participating institutions. And initially, they were focusing on the most common cancers, and then they broadened it out, I think, about 18 months ago to look at rare cancers. And as we know, there are a lot of rare cancers, and so they didn't define what rare cancers, but they have limited resources. And so they will include however many rare cancers can get them samples by the end target that they have for the project. And we have had some really, really helpful guidance from some folks at MD Anderson and other centers to help get participating institutions to help get uveal melanoma as one of these rare cancers. So this is still in the process, and I can't tell you that the contracts have been signed and that the samples have been sent, but I can tell you that we have had multiple phone calls, are working very closely with the National Cancer Institute, and have centers from, again, across the United States and Europe very interested in sending samples. And I think the forms are just about finalized to move to the next step with that. So I'm looking forward to hopefully next year at our meeting in LA to be able to give you an update on this, that everything's been signed and moving forward. But I wanted to share that with you now. So I think that's about all I have. These are some pictures from our scientific meetings so that it's more than just words. You actually can see the group of us getting together, and if you look closely, these photos are all on the internet. They may not project that well, but if you look closely, I'm sure many of you can see some of your treating physicians in the photos as well. And just to mention a few partners we have in the scientific arena. I think I've mentioned most of them already in the talk, but the National Institutes of Health, the National Cancer Institute, Society for Melanoma Research. The National Cancer Institute has a specific way of funding disease, a particular way of funding disease-specific centers called SPORES. We're working with the melanoma SPORES, and that's some of the helpful guidance we're getting with the Cancer Genome Project, collaborating with the European Ocular Oncology Group and the International Rare Cancer Initiative. So there is building collaboration in the field, and we're really proud and lucky to be a part of this. And lastly, future directions in the medical and scientific arena. These are a few things we're working on, not everything. One of the things we want to work on the clinical side is to continue building physician education programs, so to continue educating physicians in the community. We've heard from so many of the wonderful experts at MD Anderson and centers like MD Anderson, but what about the clinicians who aren't affiliated with an institution like this? So continuing to educate community physicians. As I mentioned, we'd love to be able to fund additional research awards. And furthering the development of the clinical trials network, as well as the development of the virtual tissue bank, and continuing with the TCGA. So hopefully when I speak with you again, we will have updates on all of these items. So that is the update that I have from the Scientific Steering Committee. And if people have questions, feel free to ask them now, and we have Dr. Woodman with us as well if there are specific questions about any of the research grants that you might have. And if you're tired and don't have questions, then Tim can come up and talk as well, but it's just informal. So.
Is this working? I just want to say that I feel like your initiatives are amazing, and I feel like I have someone fighting for me. If I had been diagnosed when Greg was diagnosed, I wouldn't have such an amazing support. This support is incredible, and I feel like all these initiatives are something I would want to fund. Every one of them is really valuable for the future of finding a cure. So I just want to say thank you. It's amazing.
Very kind of you. It's a team effort, so I really appreciate all of you for being supportive and helpful, and it's a team effort at the MRF as well. Thank you for that.
Okay, I think this applies. When you're talking about coming up with like standard
treatment guidelines,
and stuff, can you explain a little bit of like what the process would be as far as like once you had a standard guideline, what's the process between getting that and then like my insurance acknowledging it and therefore authorizing scans? Because that's something I know we're not alone, and we're coming up in September, will be 5 years, thank God. But at that point, according to my insurance, they will not authorize any scans anymore unless there's an issue.
Yeah.
So
thank you. Right.
Thank you.
So that's a really good question, and I will say a few comments, and Tim and Scott, if you have additional thoughts. But that is something specifically that we discussed at this meeting, and And in the context of even where there was disagreement among physicians about what the best recommendation was, some of the comments were, but what we say in these guidelines will potentially have this type of impact for patients, and we can make it easier. And so even if there's not complete agreement, hopefully the way that it will be stated there will be something for patients to point to, some sort of consensus statement that patients can point their insurance companies to. It won't be completely straightforward, I don't think, at least initially, but there will be some backup for patients and something for patients and your physicians to point to in that fight. Do you have?
So this meeting was actually fairly narrowly focused on two questions. One was, should you do a genetic testing of primary tumors? And
Should you do
a lot of
biopsy?
variation and practice, and a lot of variation in attitudes around that. And then secondly, what do you do about surveillance? You know, what is the right approach to all of this? And most people came into this meeting, and it was an eclectic group from all over the world. It was an international group, top people in the field. All the top names were there, facilitated by a very senior medical oncologist who's not in the ocular melanoma field, but well respected. And I think there was skepticism, significant skepticism going into it that anything would come out of it because of the strong perspectives that everybody had. At the end of the day, we came up with some outline statements about what to do in both of those areas. And so, for example, even people who are not routinely doing genetic testing agreed that it should be a standard of practice that genetic testing should be offered to every patient. That was huge to get people to that point. So then what's the next step out of this? The next step out of this is we have working groups looking at each of those two issues who are developing white papers. And a white paper then would be basically a statement that comes out of this summit with all of the names of the people who participated in the summit and would be published in a peer-reviewed journal. And so then it becomes more widely disseminated to the broader treatment team, and it gets implemented into practice. And then as it's implemented into practice, and on the strength of that white paper, the insurance companies will be pressured to cover what needs to be covered. So it feels convoluted, it feels a little slow, but I have to tell you two comments that came out of that meeting. One was one of the smartest people I've ever met, really, really good medical oncologist. As this person left the meeting said, I have to tell you, we accomplish immensely more than I ever thought would ever come out of this meeting. And the second is a very good ocular oncologist who had rearranged their entire clinic schedule in order to be able to attend this meeting, even though they had already been out of the office for quite a long time, and it was quite an imposition to do this. And I told this person, thank you for doing it, and the response back was, no, you don't understand. This is the kind of meeting that at the end of my career, I could look back on and say I was there. So this was a big friggin' deal, okay? It was a big deal. We aren't there yet, but there's pressure to keep moving and practicing, and I think we will get to the point where we'll be exactly where you're talking about.
Thanks, Tim.
I just had a couple of questions about Dr. Garraway's research.
Okay.
Which was, if it's identifying a spectrum of new mutations, apart from the ones that Dr. Woodman mentioned, is that...
We put the microphone down so people
So
can hear.
I understand it's about identifying more mutations than the ones that we know about and that Dr. Woodman mentioned. So is it going to be able to identify more of them, or all of them, is the first question, or do we know that? And the second question is, what's the significance of 65 tumours? Is that a significant statistical sample, or does that mean that's as many that there are available, or why is it 65?
Do you want to take it? Do you want to come up to the microphone? What? Yeah.
So the answer to your first question about the number of genes that will be looked at, we now, as I mentioned in my talk yesterday, have the ability to look at every gene in the genome in a tumor. And so the answer is it will be a complete analysis of every gene in these 65 tumors to look for mutations that are not present in normal genome of the same patient. So that's the comparison. And it's just phenomenal that we're at a stage now where we can do that. So it'll be a complete set from that 65. There's no magic to the 65. That was, you need enough material from each tumor to do it, and you need paired samples of normal and tumor tissue in order to do that comparison. And so 65 is a large number when you look at it, because even the TCGAs that have been done, where a similar analysis has been done on lung and breast and colon, etc., for those tumor types, they can range anywhere from 200 to 300, maybe a little higher in some cases. But for the rarer cancers, having 65 is actually a pretty strong number. The TCGA will add to that number, actually, because they will be doing that level of analysis, and then they will be doing RNA, microRNA, protein, and clinical data, and integrating all that data so that we get multiple levels of understanding molecularly of what's going on in a tumor. So no magic to 65, but getting 65 paired samples with enough DNA content where there was the quality control, that is quite a bit, actually.
Thank you, Scott.
Before you go, one of the interesting things, Sara said that we were able to fund the top 3 grants, which was not actually strict, top 2 of the top grants, but it's not exactly the way the conversation happened, and it's pretty interesting the way the conversation did happen. The second round of reviewers said these are really a half a dozen really fantastic studies to fund. And as we talked through it and worked through it and went on it, they said there are 3 that are just slightly better than the others. And I said, okay, can you rank them 1, 2, 3 so we can fund them, because we can probably only fund 2, and we thought we might only be able to fund 1. And they said, no, we can't rank them because they're all important. You're going to have to make a decision about what to fund. And we had one donor who was particularly interested in funding Dr. Garraway, which was one of the top 3, so that made that one easy. The other 2 grants were pretty intriguing in that one of them was built on a background that made it fairly certain that the research goals would be reached, but it wasn't entirely clear what the impact on future treatment and care of patients would be. So it was attainable, but the impact was a little bit of a question. The other one, the research goals were not quite so easily, it wasn't clear that you could actually do what this person was going to try to do. But if they could do it, the impact could be huge. So one of them was a little bit lower risk and perhaps lower reward. The other one was high risk, high reward. And we were able to go back to the donor who made that grant possible and say, here are the 2 options. Which one do you want to go with? And I was personally very pleased to say that the couple came back and said, we want to go with the high risk, high reward one. And that was the other grant. And I wonder, you don't know this background, so I'm asking you a question, Scott, that's not entirely fair, but I wonder if you could expand on that a little bit about what that means, that it's high risk, high reward in this G protein study.
Right. So Dr. Sandek, as Sara had mentioned, was off doing G protein basic biology at the structural level, looking at crystallography. How do G proteins actually bind to these other molecules in the cell and then cause that signaling diagram that I showed you yesterday to even happen? What is the molecular interaction exactly like. And this is a very difficult thing to do. But they figured it out. They figured out the sort of lock and key, if you will, the way that they have to structurally be to interact. And he found that the G-alpha proteins actually interact with the molecules in the cell in a very similar way. The G-alpha proteins take on a similar conformation. And so then he used a mimetic, meaning a molecule that looks like the molecule that G-alpha binds to, and he was able to break that interaction, okay? And more importantly, actually, he developed an assay to measure whether or not there was binding or whether or not that binding was broken. And so he now wants to look at a large number, 100,000 molecules, to see which is the best at breaking that interaction. Because as I mentioned to you yesterday, the G-alpha proteins, we don't have a direct inhibitor of the G-alpha protein. So he's going one step down saying, well, if I can't inhibit its action, maybe I can inhibit it from binding to its binding partners. Now, it's high risk, high reward in that you're going into it not knowing if 100,000, it sounds like a lot of molecules and definitely you're going to get something out of it. Well, yeah, but it could be zero. But I don't think it'll be zero. I think there will be a list of candidates, and then now you have to go to that list of candidates and further refine them, and then you have to figure out which is the best. And then once you figure out which is the best, and I don't want to speak for Dr. Sanjay, but once you figure out what is the best, then you have to figure out how do I get that best molecule into a form that can be deliverable to a human being, right? So that's a long way from a therapy. But that being said, if he finds a molecule or set of molecules that really can inhibit this interaction of G-alpha proteins with their binding partners, that would be a huge breakthrough and could be a huge therapeutic breakthrough down the line.
Good question. Thanks for the answer.
So you'd mentioned that there's 2 grants that were funded, and I believe you said they were both for $200,000 each over 2 years. Is that correct? Is that the normal price tag of a research grant? I mean, while I'm not in a position right now to write a check for one of them. I don't think that's a lot of money. You know what I mean? So is that typical, I guess, of how much these grants are?
So I think that's a.
To follow up just on, is that $200,000 going to satisfy the research parameters, or is Dr. Sondek or Gary going to have another one in order to finish?
Who wants to answer that? First of all, I think that is not only a great question, but I think in a lot of ways that's the key question.
I have a magic microphone now. So now I really do have a big voice. So the answer, so research, I have to tell you, research is a bottomless pit. You could throw $500 million at it, and it wouldn't be enough. But you can sometimes throw smaller amounts of money at it in the right way, at the right time, on the right study, and it can make a big difference. So the challenge then is, if we're going to give out $3 million of grants this year, do we give one $3 million grant? Do we give a whole bunch of $1,000 grants? How do we find that balance? And so we've been funding research at the Melanoma Research Foundation since 1998. And we work very closely with very senior scientists who direct that research program. And the guidance they have given us is we have 2 initiatives. One is $50,000 a year for 2 years. The other is $100,000 a year for 2 years. One is for people who are newer in their career. One is for people who have proven their ability to do things in the year. And the thinking is this is enough to get a program up and running. And if there's real promise there, they can leverage that study to go back to federal funds and get what are called R01 grants or things like this that might be $3 million over the next 5 years. They can use this data to leverage additional funding. Or in some cases, it may generate enough data in a particular therapeutically promising area that they can get a pharmaceutical company involved and interested in doing more. So is that the right level? I don't know. We would love to have another level where we were funding fellows, research fellows. That would be a one-year grant at something to $20,000, $30,000 or something like that. We're having some conversations about this. But every year we struggle a little bit with how many grants do we give out at this level and how many at this level? And this seems to be the best balance. And it seems to have paid off. If you look historically at our history, that we funded some things that actually have turned out to be quite promising and beneficial.
And one other thing that I might add, and Scott and Tim, you can chime in as well, is that there's another level that has been in discussion in the medical community in the ocular melanoma field, which is funding clinical trials. So the question of adjuvant trials, which Dr. Patel talked about yesterday, has come up, and a lot of people have asked, well, what's the range, what does a clinical trial cost? And so when we've been talking about, well, how do we fund an adjuvant trial, for example, the number about $500,000 is what people have come up with for getting a clinical trial. Is that? And up, right. But that would be a starting point, just to give you a range that that these grants that we're funding these aren't clinical trials, the ones that we're funding at this level, and so that's sort of a range of the scientific piece, and then clinical trials are sort of a different ballpark.
Yeah, so we're involved in a clinical trial through the consortium that's just beginning to get up and running. It's a phase 2, a fairly robust phase 2 trial. So, clinical trials are phase 1, phase 2, phase 3. Phase 1 is around dosing, phase 2 is around safety, phase 3 is, I don't know, it's the more robust big trials. We are not going to be able to do phase 3 trials. This phase 2 trial is about a $3 million trial. And not all trials need to be that robust. You can do phase 1 trials that are smaller. You can do smaller phase 2 trials. But yeah, $500,000 would be the minimum, I would think.
I think very minimum.
And that would be a bare bones trial
and supplemented in other ways, probably.
Yes, probably so.
Yeah. So then that's the thing about research is that, $200,000 in isolation doesn't do much. You're absolutely right. But all of us who do research, we have different mechanisms of support, either from our institution, from the NIH, from foundations, from philanthropy, and you cobble things together to get things done. Now, you have to submit a budget, of course, for any proposal, and you have to justify how you're going to use that $200,000 and how you're going to get to the end point, which in these two have endpoints. But, for example, Dr. Garraway has funding from the government to do sequencing through the Broad on cancers in general, and so this money will help to subsidize greatly, the 65 that he's going to be doing. And I, as a scientist, you have a vision, you have something you feel is going to, change the field or change the reality of an understanding, and you're going to just do everything you can to get it, right? That's how I think all of us feel. And so 200,000 is a nice boost for sure, but it's not in isolation. Yeah.
That's an important question.
It is a very important question.
And I think actually it leads us into the next part of our wrap-up talks, which is how to get involved and how to support this work and how to keep moving things forward. So if there aren't any other questions on the scientific piece, Tim, do you want to take over?
I asked for this microphone because I don't want to stand up there. I have 45 minutes to give this talk, and I have to be finished by 1:45. So I need a research story on how to research project on how to suspend time. But the thing that's really great about my speaking at the end of the day is you can see how I've kept the crowds here, and nobody has left. Only the important people are left, right? Exactly. Only the important people are left. So I put together this whole slide presentation, and I think I'm just going to ignore it. So we'll just, because I can't go through this and be finished at 1:45. Yeah, I could go really fast. I've seen people do that, you know, like, okay, you have 30 seconds left for your presentation and they still have 75 slides through and they won't cut anything out. It's like, and this, and this, and this, and everybody's like, I don't get that. So let's, yeah, they're right, it would be a terrible thing. So let me ask you this. You've heard a lot about where we are in ocular melanoma right now. Treatment options, the way patients are being treated out in the field, and you know, whether they're getting the right kind of counsel and the right kind of advice and the right kind of care, whether the treatment options work or don't work. You've heard a lot about support and networks and familiarity with this. So are we where we need to be? Yeah, I think we have consensus around that one. There's work yet to be done, and I would venture to say a lot of work yet to be done. I mean, you saw the statistic, right? And you guys know this because you live it. Once a person has a metastasis to the liver, it's a 20% 5-year survival rate. That is not okay. None of us are okay with that. Now, fortunately, statistics are not individuals. And what a study says about a large group of people over the past several years has nothing to do with what will happen to a single person over the next 5 years. So we can't freak out over the statistics, but we also can't ignore them and stick our head in the sand. So it seems to me that we're in a situation that's not tolerable. It's not okay. So what would we want it to be? Right? If we could write out what the ocular melanoma space really looked like, what would we want it to be? And it seems to me that it would be a few things. One, every patient would be given the kind of treatment that they deserve. Every patient would have a network of support, so they don't have to walk this journey by themselves. Patients would have the information and the support they need to live as long and as well as possible. Doctors would have safe and effective treatment options. And bottom line after all of that is we would see far fewer people dying of this cancer. That's the bottom line. Ideal world would be nobody would die of this cancer. We know that's not likely to happen. But what is likely to happen, I believe, what is accomplishable, what can be done, is we can see those numbers change dramatically. So the question is, how do we go from vision to reality, right? So this is the vision, but it has to be something more than just wishful thinking, because wishful thinking won't change the world. And hope is more than wishful thinking. And it strikes me that hope is not something you wait for someone to give you. It's something you earn and something you work for and something you strive toward. So how do we move from vision to reality? Well, the first step, it seems to me, is that nobody's going to take us there. I had this little cartoon. You've all heard the story about when you consider preparing breakfast, there's a difference between the chicken and the pig. The chicken is involved and the pig is committed, you know. And there are a lot of people who are involved who care, you know, but there are a lot of people who care. You have friends and you have family who care, but the fact is there are a lot of things for people to care about. You can care about tsunami victims and hunger victims and victims of shootings in schools, and you can care about breast cancer and lung cancer and colorectal cancer and pancreatic cancer and all these other kinds of cancers, and you can care about all of this stuff, and there's so much stuff for people to care about. The ones who really are going to be passionate and committed, because it literally is a life or death thing, are the people right here. So the people who have the capacity to move from vision to reality are folks just like you. And so you have the passion and you have the compassion, you have the real need for this to happen, but you know, a lot of folks, you're also struggling, right? How do I make it through this treatment? How do I make it through my next scan? I can hardly even bear to think about going to my next scan because of, you know, the scan anxiety. And so it's tough. But the fact is, if you look at all of the big fields of life-threatening illnesses, the people who have really made a difference have been people just like you. So what does that mean? What does it take to make those steps? Vision to reality, vision to reality. And I would say it falls down to two things, community and money. So community, I said it Saturday morning. I loved walking into this room early Saturday morning and hearing the level of chatter around these tables. And I've heard so many of you say how amazing it has been to meet people who really understand what you're going through. You know, I had a conversation with a woman a short while ago who said, I have this great big network, 80 first cousins. That's a big network. And all these friends and all these family, and she said, but they don't know what BAP1 mutation means. And they don't know what GNAQ and GNA11 means, and they don't understand what liver metastases mean. And now I've found people who understand that, who know the language, who talk like I do. Community is so important. We have an active bulletin board. As some of you know, we have an active Facebook presence. I cannot overstate how significant the input of all of you into those spaces is. For everyone who responds on those places, there are dozens of lurkers who don't respond because they feel too vulnerable, they feel too shy, they feel too uncomfortable, but they are taking information from there and comfort from there and solace from there, and they're building friendships, and they may view you as their best friend in this journey, you know? They may really see you that way, even though you've never seen them post and you don't even know who they are. And I know this because sometimes they come back to me and say, I just want you to know I've been reading the bulletin board, and our online bulletin board actually predates us. I've been reading your bulletin board for 10 years. It has changed my life. I've never posted, but it's made such a tremendous difference. We have a buddy program where you can go through training and be paired up with another patient or a caregiver. I mean, we heard so powerfully yesterday the toll that this takes on caregivers. To be paired up with another patient or another caregiver. Volunteering to do that, if you can, and you may not be in a place where you can do that, but volunteering to do that is a tremendous gift in building community. Okay, I've left myself 90 seconds to talk about money, which you probably all appreciate. So, the biggest source of research funding in the country for medical research comes from the National Cancer Institute, the National Institutes of Health, and in oncology, the National Cancer Institute. And I said I wasn't going to show you slides, but if I can make this clicker thingy work, I'm going to flip through to one slide because I want to show you some numbers. There's the chicken and pig thing, sorry. Look at, so I don't know how well you can see this. Good. So this is the success rates for people who applied for grants from the National Cancer Institute in 2011. And the two big grants, there's an R01, which is the one that is, you can get $500,000 a year for 3 or 4 or 5 years. You can get $3 million grants, those kinds of things. And the R21 is a $500,000 thing that's to encourage new studies, right? And so if you look at experienced investigators, 16% of R01s were funded, and 14% of R21s were funded. And if you look at new investigators, it's much lower, 13% of R01s, 8% of R21s. That means you are so at this point, you have finished your undergraduate degree, you've done a master's, you've done a PhD, you've defended your PhD thesis, you have done a postdoc after your PhD, for 2 or 3 or 4 years, and now you're trying to get research funding, and you bust your butt, and you write a grant that's about this thick, using the best information and knowledge that you have, and if you're a new investigator, you've got an 8% chance of getting funded, and if you don't get funded, you don't have a job. And I'll tell you what is happening right now is the best and the brightest people who are coming out of our colleges and universities are not pursuing PhDs, and they're not going into research because they don't think they can be employed. And the impact is going to be on the cures and the treatments that we need down the line, because the folks who are doing things like this G protein work, they won't be there. This is a major, major problem. And we all can have a voice in this problem by writing our members of Congress and saying we need more research funding. Here's my story. Here's my story. I have a cancer that I have a 50-50 shot that I'm going to have a metastasis, and if I do, I have an 80% chance that I won't live the next 5 years. And the only way I'm going to find better solutions is through more research. And we have seen this number, these percentage numbers, going down year after year after year. Fewer and fewer grants are being funded in the NCI. We've got to turn this around. So, other money. You know, you guys can all be involved in generating money for this cause. The easiest way is to write a check, but, you know, not everybody, you know, we could all write a $500,000 check. It's just for most of us it wouldn't go through, right? I mean, some people can do that, and we had very generous donors who helped make this happen. I understand that most people don't, and especially when you're going through cancer treatment, you know, your money is kind of being used in other places, and you kind of kind of thinking maybe I need somebody to write a check to me. I understand that. But there are a lot of things that can be done, and a lot of people would like to help if they knew how to help. We've had people who've said, I'm going to set up a fund, and you know, so for example, we had a person who had a relative who had melanoma, who said, I'm going to set up a fund in my relative's name, and I'm going to ask everybody, instead of giving me birthday presents, to write a check to that fund. And instead of having an anniversary party, we'll write a check to that fund. And we're going to do a little yard sale and give the proceeds to that fund. And all of a sudden, it was $5,000 or $10,000 that came out in the name of their loved one who had melanoma. And it wasn't because they wrote a big check. They couldn't write a big check. It's because they got a lot of other people to help out. The number one reason people don't give money, they're not asked. And we're really good at asking for money when we're young. Have any of you had 2-year-olds or 3-year-olds? Can I have that toy? No. Can I have that toy now? No. Can I have that toy now? No. Can I have some candy? No. Can I have some more candy? No. Kids are really great at that. Shelby, who's back here, has a daughter who's now 8 months old. Soon be 8 months old. You'll learn this very soon. When we're kids, we're not shy about asking for stuff. And for some reason, our gestalt, our mindset changes, and we get uncomfortable with it. But the fact is, this is not about asking money for ourselves. This is about saying, look, there's an unmet need here, and you may not even be aware of it, and help out. If you had a close friend who was facing a life-threatening illness, and you could make a contribution to help in the fight against that illness, I mean, you would want to do it. So we can give our other friends and our family members an opportunity to do that. We have a number of fundraising events that we do through the Melanoma Research Foundation, and we have said that anytime there's someone associated with ocular melanoma who wants to participate in that event, if they want to participate and say this is for Cure-OM, 100% of that money goes straight to this program. None of it will go to cover the cost of the event. None of it will go to cover the T-shirts at the walk or the flyers announcing it or anything like that. We're covering all of that out of other funds. 100% goes to this program. So we'll do a 5K run walk at Universal Pictures backlot in Los Angeles in early May. We'll have a Cure-OM team there. We're doing gala events, all of those kinds of things. If you see something going on, great. If you want to start your own event, let us know. We'll help you to the extent that we can. All right, I'm almost at quarter till. Yeah. No. I'm supposed to finish at 1:45. So I'm almost there. I want to point to one last thing, though. Come on, clicker. Thank you. And that is this. Why should you give to CureOM? The fact is, you have a lot of choices. I introduced, and they've both gone now, but I introduced earlier two people who are here from the Ocular Melanoma Foundation. I know a number of you are on the Facebook page for the Ocular Melanoma Foundation. You've been at events that they've done. You could give money to them, or you could give money to us. We would prefer you get involved with us as a volunteer, as a partner, as a thing. But frankly, I got to tell you, I'm more concerned that you do something. Here's who we are, and then you can make your own decisions about what to do. I think one of the things is about vision, mission, and strategy. Sara is one of the more visionary people that I've had the opportunity to encounter. She does not think small. And when we launched CureOM in November of 2011, she said, we're going to push hard to get $1 million of research funding quickly. And I said, well, we'll work toward that, and we have to be patient. And she said, no, I'm not interested in being patient. Well, right now we're at 800,000. Reality follows vision if your vision is right and you have a good strategy around it. And our vision is to change the world. And frankly, if we're not going to change the world, I'm not interested in fooling with it. I got other things to do with my time. But we're going to change the world. And we're going to change the world for melanoma patients. We're going to change the world for ocular melanoma patients. Because anything less than that is not acceptable. And I think we have the vision to do it. I think our mission speaks exactly to that, and we are developing clear strategies to help make that happen. The culture, I talked a little bit about this Saturday morning. I cannot overemphasize how important this is. I mean, we talk about this all of the time, about the right culture, transparency, making sure everybody can see what our plans are. We don't have secrets here. We make sure we post our financials. We make our 990s available. That's the IRS tax form. We submit all of this to the Charity Navigator so it can be reviewed and evaluated. We work very efficiently. We make sure that as much of the money that comes into us goes directly to program as possible. And we're entrepreneurial. We are not going to change the world by being risk averse. We have to take risks, and some of those risks will not pay off. And we'll have some fiascos along the way, but more of them will, if we're very careful and we're really smart, and we can be entrepreneurial and see the kind of growth. And I have to say, I'm really pleased. We've got a great team at MRF who have been working really hard. And in this economic environment, for the last 3 years, we've increased revenue by 25% each year over the previous year. And I'm frankly anticipating an even bigger increase this year. And all of that means more research funding, more support for patients, more awareness, all of those kinds of things. And we're focused on patients. We are a grassroots organization. Most of our money comes from small donations. We get a few larger donations, but most of it comes from small donations. And it keeps us connected and grounded. We never want to forget who we work for. We work for you. And we are not interested in being patronizing, being top-down. We're interested in listening and hearing, acknowledging when we need to make improvements, acknowledging when we've made mistakes, acknowledging where we still have more to learn, and moving forward from that. And this is all important to us. So the thing is, if this is something that resonates with you, and if it's something that is real, we'd love for you to get more involved. And whether that's as a volunteer, as a fundraiser, a donor, whatever, let's do this together. I had words to a song up there. It's kind of a sucky song, but it means a lot to me personally. But it talks a little bit about hope. And I will say this. I see what has happened in these last 2 days, and the hugs that you've shared, and the tears that you've shared, and the stories that you've shared, and the laughters that you've shared. And in many cases, I've been able to be part of those things, so it's been we who have shared those things. And it is so inspiring. I have to say, it is so inspiring. how could you, looking at the love and compassion and the commitment and the passion that you have, how could you look at this group of people over these last 2 days and not have hope? That's where the hope comes from. So for that, thank you very much. And I'll be quiet, and I didn't quite make quarter till, and I apologize. So.